ठीक है, देख मैं ज्वाइन हो गई ना, मेरा म्यूट आ रहा है।
Hi, sir. Can you hear me, Mohan, sir?
Yes, yes, I can hear you. Yes, audible, audible. Yeah, yeah.
Can we have one of the presenter who shares screen and present? Who are them? You are able to recognize them? Yeah. Someone, you please come here so that you can talk to them.
Dr. Komal Jog, Dr. Ramiz Raj, are you ready? Hello, am I audible? Dr. Ramiz, am I audible?
Yeah, they can unmute.
He's not hearing me.
Needs to unmute.
Dr. Ramiz.
Mohanchina is there.
Yes, sir.
You can say hello to him.
Good afternoon, Dr. Mohan, sir. Mohan, sir. Are we not?
Yes, I'm here already.
Sir. Good afternoon, sir. Good
So you
afternoon.
can just start. I'm here already. I didn't get the
Yes.
judging sheet, so if I get the judging sheet, it will be easier.
Sir,
for
I've
me.
sent it, sir. I've sent it via email and WhatsApp both,
Okay, I
sir.
will check it. Okay.
Yes, sir. Dr. Ramiz, am I audible? Dr. Komal Jog,
They are not unmuting.
please unmute. Dr. Ramiz Raja, please unmute.
And please switch on your cameras.
Your time will be over. You are going to tell them that the time of presentation is going
Yeah,
to
the
be
time is running out actually. Dr. Jaspreet Kaur,
Please unmute. If you
Can-
have any problem in unmuting, just write in the chat box. Because we are running out of time. Now, see what the chat box.
Just see that.
Right there, please unmute.
Hello?
You lose your time. Yeah, somebody
Dr. Ankit, can you hear me, please?
Yes, I can.
Okay, Dr.
Please start
Ankit,
presenting.
can start presenting. Dr. Ankit.
You can share your screen and present. You've got 3 minutes to present.
I
And
have to share my screen.
Please share your screen and present.
we have got 3 minutes for discussion, for presentation, and 2 minutes for discussion. We have the judges who will have may have a few questions for you. Please go ahead.
Can you see my screen?
No, we are waiting to see that.
Your screen sharing is slow. Sir, I have shared my resume share.
Yeah, can you stop and do it again, because we can see that you have started that, but it's not happening.
It's going live on.
Try again.
Yeah, I will not make it live.
So now can you see?
Yeah, we can see your screen. You can start.
Okay, sir. Good afternoon, respected judges. My topic for the poster presentation is assessment of discordant rates and its factors which influence the management outcome by Frank's prediction model with and without BMD. So DEXA, as we all know, DEXA is the main thing which is used for the diagnosis of osteoporosis. But currently, in the resource constraint setting in India, the availability of DEXA ideally should be around 10.5 per million population, but it is currently only 0.26. So, and because of the fallacies in both DEXA as well as FRAX, so there are discordancy that we are seeing. So my objective for this presentation was to compare the FRAX without BMD and FRAX with BMD.
You can see here till we fix
the
that.
10-year probability of major osteoporotic and hip fracture in our Indian settings. It was a retrospective cross-sectional study which included around 354 subjects, and the subjects were divided in two groups. Each and every subject was calculated FRAX without BMD and then with BMD. Then the two groups were divided as concordant and discordant depending on the 10-year probability of hip fracture. If it was more than 20% for osteoporosis or more than 3% for hip fracture, or both on the lower side, they were classified as concordant. And when the results were on the opposite side, it was classified as discordant. the population was included up to 40 to 90 years. So what I found was the around 80.5% of my population was in the concordant range. That means that they had same risk fractures for the fracture with BMD or without BMD. As you can see in my first table with the baseline population, the discordant population, majority of them consists of the male population, and the age was above 63, which was significantly more than the concordant rate. And the bone mineral density as both hip and spine were lower. When we look at the age-wise distribution, the discordant population basically comprised of the 6th decade of the population, whereas on either side, it was more of the concordant group. When we look at the risk factor distributions, which are 7 risk factors in the FRAX, the presence of parent hip fracture was more in the favor of concordance group, whereas the use of glucocorticoid, alcohol, or smoking were more significantly present in the discordant group. Then the osteoporosis was also much higher, around 89% in the discordant group, whereas osteopenia was mainly present in the concordant group. So when we looked at the treatment on the basis of osteoporosis, in the discordant group, the FRAX alone in around 11 cases, which was 3% of our population, accounted for the treatment, whereas which was not identified by doing FRAX in BMD. There are similar studies also present in the past, like one in the 2018 done in Sri Ramchandra Medical College, Chennai, and another outside India in 2013, which also showed around 86 to 84% concordance rate. So to conclude, the younger age and the parent hip fracture is more indicative of identical risk prediction, whereas male sex, use of alcohol, smoking, or glucocorticoid may falsely show the low FRAX values when done without BMD. So FRAX alone in the resource poor setting, like where the DEXA is costly and unavailable, can be used as an alternate method to predict osteoporosis and can be also a good screening tool. But further research is still needed on a large scale population to classify FRAX alone for the osteoporosis. Thank you.
Okay. So, Sudhakar sir is there?
Yes.
Sir,
Yes.
Please, sir. Your questions from you, sir, first.
First you start. Mohan, you can proceed.
Okay, sir. Shall I ask a question?
Yes.
Okay. Good presentation, doctor. So
Thank
the
you.
data is regarding the east side, no? So already existing data is from South India,
Yes,
and earlier data was from Las Vegas. So you mean that this is a comparable study? Yours is compared to these two studies?
Yes, sir. My
Okay.
data showed 80% concordance, whereas those
Yeah,
studies
I
showed around
understand.
84 to
I
86.
understood. You have a patient number also matching similar or even more than that?
So more than that, I had 354 patients in total. They had around 240.
My question was, your exclusion was including patients, but you have not excluded diabetics or anything, no? Your
No, sir.
exclusion does not include metabolic diseases.
Metabolic diseases like osteoporosis were excluded, sir.
Excluded. Okay. So you are already mentioned the reasons. But my question is regarding the female patients who already had on treatment. Did
They
you
were
know
excluded.
the status of their previous? Do you have a baseline data of theirs also?
Sir,
Female patients.
the patients who are already on osteoporotic treatment were excluded from my study.
Okay.
Sir.
Okay, so the studies, what is the one point which you are finding better in your study than other study?
So what I didn't get you, sir?
What is the one point in your study which is actually better than your study, other studies?
So point is, sir, the age factor, first of all, and the other studies that have used, they have just used the postmenopausal or the ages above 50 to 60 years of age.
Do you think that bone turnover markers could have been done in these patients, or do you have the data?
This was a retrospective study actually, so the bone turnover markers was not possible to do.
That's one thing which I find that we may have to do in such, because other things are good in your pattern. You have compared the FRAX BMD with the alone, and you have done a excellent job. But only thing, we have the database, which I think we are using the majority database.
Yes, sir.
So I think I am quite understanding your study. So yeah, so that's my side. Sudhakar sir, you can please ask questions, sir.
So what is the younger cutoff age 40 to 90 or 50 to 90?
40 to 90, sir.
Why that 40?
Sir, because Frax calculation is actually based for 40 to 90 years. So that's why we use the population of 40 years also, sir. Above 40.
No. Okay, we can proceed to next one.
Thank you, sir.
Dr. Ramesh Raja, please start presenting.
16 second.
Time starts now.
So good evening, sir. Sir, my presentation was a rare case of sclerosing bone disorder with syndactyly. Sclerostosis, a case report. So sclerostosis, we know that is a rare sclerosing bone disorder with autosomal mode of inheritance. So it is due to the two loss of function mutation of SOST gene that encodes sclerostin or LRP4 gene mutation, which is a sclerosing core receptor. And the prevalence is very low. It is it is usually reported many cases only in African or South Africa region. Whereas in India, there are only few cases are diagnosed. Among these, only one cases are reported in the literature from India. That is from JIPMER. So, a 34-year-old male presented with right-sided headache and facial pain with progressive hearing impairment and progressive visual impairment for the past 6 months. So he was born of a consanguineous with strong family history of similar illness. His father as well as his cousins were also affected. On physical examination, his height was 175 centimeter with the frontal bruising and displaced nail, syndactyly of left third and fourth finger. On fundus examination shows bilateral papilledema and Putin automation bilateral moderate neurobearing nerve, which indicates there is multiple cranial nerve entrapment. His complete blood count was normal, whereas his serum calcium, phosphorus, alkaline phosphatase, PTH level were normal, whereas serum 25 vitamin D was such insufficient range. The CT bone of the CT brain shows a diffuse thickening of the skull bones with the dilation of ventricle. The skeletal survey also shows there is increased density in long bones such as femur, humerus, etc. So we know that the sclerostosis is a rare sclerosing bone disorder, which is due to the mutation in the SOST gene. So that is responsible for anabolic bone formation. So identifying these responsible genes, their mechanisms of action is useful in the treatment of these disorders as well as facilitate the development of therapies for osteoporosis. Thank you, sir.
So yes. So clinically, when would you suspect this problem?
Sir, usually a patient presented with multiple cranial nerve involvement, such as especially trigeminal nerve or optic atrophy, when multiple lower cranial nerve involvement, there is, you can suspect this sclerosing bone disorders. Also, when patient presented with pancytopenia, with increase in bone density of the skulls, then also we can suspect sclerostosis. That's sclerosing bone disorder. One of these is sclerostosis.
One question from me.
Yes, sir.
Yeah, what is one thing that makes it unique from the Paget's disease? Paget's disease of bone.
So, Paget disease is uncontrolled osteoclast bone osteoclast bone resorption, whereas it is due to uncontrolled osteoblast formations, bone formation. As I think due to excessive bone resorption, it is due to excessive bone formation. Where there is excessive lytic lesion is present, here is excessive increase in bone density will be present. That is thickening of bones.
Yes, yes. So both are almost like thickenings only, but I think you have done a great thing. So this is a rare case. So that's it. So you have worked out the case well. I think follow-up is due now. So patient is due for follow-up.
Yes,
What
sir,
is
sir.
one thing which we look at the follow-up in the progression of this patient?
Actually, especially we mainly follow where there is any presence of pancytopenia, sir. Because when development of anemia, leukopenia, pans, which is because due to sclerosing of the bone marrow, these findings are common. Also, we can look for any increase in intracranial tension, sir, due to compression of the foramen marrow and then the compression of the foramens. It can also cause increased hydrocephalus. This also we can look for that also, sir.
Yes, yes. So enough. I think we can proceed to next one.
Thank you, sir.
Dr. Komal Jog, can you start presenting?
2, 3.
Your time starts now.
Good afternoon, respected teachers. Today I will be presenting a case of type 1 dependent rickets. So rickets, as we know, is a bone disease associated with widening and delayed mineralization of bone matrix. It may be either due to deficiency such as calcium, phosphorus, or vitamin D, or due to mutations which are encoding proteins
Please share the
involving
screen.
vitamin D or phosphate.
Sorry, please share the screen.
Please share the screen.
Yes.
I have shared, ma'am, yet not visible.
1 second, sir. Sorry. Yes.
Is it visible, ma'am?
Yes.
Hello.
Yes, proceed.
Is it visible, sir?
Yes, yes.
So the 6-year-old male child who was born out of a consanguineous marriage came to us with history of widening of wrist, which was noted at 6 months of age, chest deformity and deformity of upper and lower limbs, which was noted at 2 years of age. The patient also had history of delayed motor milestone of walking. However, other milestones such as social milestones, language milestones were according to age. Then he also had history of premature loss of teeth. However, no history of alopecia. So he had consulted for these complaints and he was given calcium and vitamin D supplementation, but he did not have any response to the above treatment. So on examination at the initial visit, he had pot belly, wrist widening, rickety rosary, tooth decay, premature loss of tooth, bilateral tibial anterior bowing, and bilateral cubitus variance. At presentation, the biochemical profile showed hypocalcemia, hypophosphatemia, high levels of alkaline phosphatase, parathyroid hormone levels, and 25 hydroxy vitamin D levels. And also the urinary calcium was also low. The 24-hour urinary phosphorus was also low. The X-rays which were done at presentation showed cupping, fraying, splaying, and widening of metaphysis. The patient was then started on tablet calcitriol, 0.25 microgram once followed up. Further investigations revealed that there was a gradual improvement in the biochemical parameters and resolution of X-ray changes and deformities. The serum calcium improved, the serum phosphorus also raised, the alkaline phosphatase gradually decreased, serum parathyroid hormones came back to normal limits, and the X-rays also showed the resolution of the previous metaphyseal changes. So based on this, a diagnosis of type 1 vitamin D dependent rickets was made, and the patient is now monitored with serum calcium, serum parathyroid hormone levels, and urinary calcium and abdominal ultrasonography. So the learning points are that vitamin D dependent rickets is an autosomal recessive disorder caused by inactivating mutation of CYP27B1 gene. This condition should be suspected when the biochemical and X-ray parameters are not responding to the calcium and vitamin D supplementation, and also when there is family history of such disease. The diagnosis is confirmed by measuring the serum levels of 25 hydroxy vitamin D and 125 hydroxy vitamin D levels, and treatment is with physiological replacement doses of calcitriol. Monitoring should be done with serum calcium, parathyroid hormone levels, and urinary calcium, which should be maintained in the normal range. Thank you.
So anything unusual in this case, or is it a classic presentation of this type 1?
It is a classical presentation. The patient was not responding, later he responded to calcitriol.
Looks okay to me. I think the case is well presented. So you have to keep a vigil of this. So As a student in endocrinology, how common you find these scenarios?
Sir, it can be quite common, sir, because many people will not be responding to vitamin D and calcium. So in those patients, we should always keep a lookout for such possibilities.
Okay, so how do you say that growing ends that vitamin D is totally deficient? What are the classic things you look for?
Sir, like pot in vitamin D deficiencies.
Yeah. Just I wanted to know from you.
Like the widening of the wrists,
That you
the
have
presence
mentioned
of.
here. That you have mentioned
Yes,
here. So we know that the child is growing. No, what are the sign do you look for in the growing?
if there is alopecia, it means type 2 vitamin D resistant.
Yeah. So that's all. The classification should be always thorough, and X-ray should always help. Harrison, Sulcus, all those things you can always do it in a clinical examination. But X-rays are always this. X-ray is very unique, for this case. No, all these things are quite fitting with this case. Yeah.
Yes.
So I think you have done it. So
Yes.
congrats. So next person can be. My side, no more questions. Yeah.
Yes. So we'll proceed to next one.
Just Dr. Jaspreet. First case.
Are you able to see my screen?
One X-ray is seen. So you please present the screen. Yeah. One PowerPoint screen you present.
Are you able to see my screen?
No.
No.
I have. Now, just see.
Yeah. Please make it full screen.
Yes, I'm.
Yes.
Please start presenting.
Yes.
Yeah, make it full screen, no?
I'm trying to make. Actually, is it okay now? Are you able to see it in full screen?
Yes.
Okay. Good afternoon, faculty. Good afternoon, teachers. I want to present a rare case of giant parathyroid adenoma along with review of literature. Giant parathyroid adenomas are rare type of parathyroid adenomas which weigh more than 3.5 gram. They have features distinct from parathyroid adenomas, and they have some features similar to parathyroid carcinomas. So I'll be discussing some these features along with our case. In our case, a 27-year-old woman presented with pain in leg along with difficulty in walking. On evaluation, she was found to have fracture of neck of femur, and she was not able to recollect any incidents of any trauma. On evaluation, she was found to have PTH-dependent hypercalcemia. On further evaluation, we did an ultrasound neck, which showed a well-defined heterogeneous hypoechoic lesion with well-defined smooth margins, which was suggestive of parathyroid adenoma. And system scan showed increased tracer localization to the inferior aspect of the lower lobe of the right thyroid gland. She underwent right inferior parathyroidectomy, and the adenoma weighed around 20 gram and was excised. I have shown the figures of the system scan along with the excised parathyroid adenoma. Histologically confirmed it as a chief type cells, which are the main constituent of that adenoma, and there were no signs of any capsular invasion or vascular invasion. On post-operatively, she developed hungry bone syndrome and was managed aggressively with IV calcium. Along with this, we have done the review of literature of giant parathyroid adenoma, and we found around 39 cases in English literature. And in all these cases, the mean age was around 50 years of age. They were mainly predominantly females. 77% of the patients were female, and most of these adenomas are localized to thyroid in 77% of the cases, whereas in 23% of the patients they were localized to mediastinal region. Usually, as compared to parathyroid adenomas, which are usually silent, these are symptomatic in 82% of the cases, with renal stones being the most common manifestation, followed by neck swelling, followed by fracture, and followed by very rarely parathyroid crisis. In all these patients, we found the mean serum calcium level around 13.5 and serum PTH level around 1.98 picogram per ml. And hungry bone syndrome as a complication is found in 15% of these patients. When we look at in concluding, the learning points from them are like, if they are always symptomatic, first things which distinguishes them from parathyroid, normal usual parathyroid adenomas. Second thing is that they usually present with neck masses, so on examination they can be easily found on palpation. Third point regarding ultrasound finding, they have smooth borders and they don't have any metastasis or irregular borders, which distinguishes them from parathyroid carcinoma. And usually these patients are symptomatic, and post-operatively also there is a high chances of hungry bone syndrome. So a clinical vigil should be applied while all these cases. This concludes my presentation. Thank you, sir.
Yes. So how would you differentiate this benign versus malignant?
So benign versus, first thing is like benign in these have usually early onset. In our patient it was 27 years. Usually parathyroid adenomas are more common in 5th to 6th decade of life, and if they are associated with Men's syndrome, they can come early. When we did the review of literature, we found only one case of giant parathyroid adenoma having bilateral location, which presented early also and was associated with Men's syndrome. Otherwise, we were not able to find many giant parathyroid adenomas with Men's syndrome, mainly because in men, because of the other symptoms, other presentation, gastrinomas or insulomas, patient come early. First thing is this. Second, they are always symptomatic as compared to other parathyroid adenomas. And investigation wise, usually they have parathyroid PTH levels more than 350. In our case series, we found in 39 cases mean PTH level was around 1.98 picogram per ml, so which are very high, and mean serum calcium was 13.5. So they have more usual presentation. Biochemically, they have more severe hypercalcemia and more severe increased PTH levels.
Excuse me, your time is up.
Yes. Okay.
Going to the next presenter, Dr. Priyadarshini. Dr. Priyadarshini, you can start sharing your screen.
Yeah, ma'am. Thank you.
तो शेयर
म्यूट कर दिया.
Is my screen visible, sir? Anna?
Not yet.
It's taking time to load, so you wait. Yeah, now it is with. Yeah. You can start. Yeah.
Time starts now.
Yeah, very good. Very good afternoon, and all, ma'am and sir. And today I would like to report one of interesting cases from our institute. And I am Dr. Priyadarshini from SRMC Chennai. And two rarer diseases present in the same patient is what I am going to report today. It's a Pycnodysostoses and FGF23 mediated hypophosphatemia, which is associated in the same patient. To start with the Pycnodysostoses, we all know it's a rare autosomal recessive disorder caused by cathepsin K mutation, and this has got a characteristic feature. And here with I report a 41-year-old female. She was a known case of Pycnodysostoses. She was under our follow-up, and now she came with complaints of severe bone pain and recurrent fractures. But her fractures were not healing for the last 2 to 3 years. and there was a delayed healing, like it went on unhealing also. So on clinical examination, she had a typical pycnodysostiosis feature. She had a short stature. Her height was somewhere between 3rd to 10th percentile, and midfacial hypoplasia, as we could see in the picture, and micronathia, retronathia, and she has got a grooved palate, high arched palate, dental malocclusion, supernumerary teeth, beaked nose, and decidual teeth, enamel hypoplasia, and short stubby fingers with distal acral osteolysis also. So we wanted to investigate why it was not healing. So we went on to the basic investigation first. So the routine investigation like complete blood count, DSR, renal, liver function, and everything turned out normal, and her metabolic profile like thyroid and diabetic and uric acid profile was normal. We went on to explore the bone mineral profile, calcium, magnesium, and alkaline phosphatase, PTH, storage form of vitamin D. Everything was within normal limits except for the phosphorus, which was consistently low. So we went on to evaluate the causes for hypophosphatemia, and after ruling out malabsorption related symptoms, we wanted to know whether it could be due to renal phosphate wasting, and we went in for TMP-GFR. This TMP-GFR was also low, so to indicate there was a renal loss of phosphate. So urine metabolomics and mineral analysis was done just to rule out any causes of renal tubular acidosis. So it again came out to be negative. The FGF23 we sent was high. It was above the reference range for that level of the phosphorus. So we quickly ended up looking into the other causes of FGF23 rise, like epidermal nevus or melanocytic nevus or any fibrous dysplasia with whatever X-rays that we could get. It was negative. So the patients being gallium dotatate PET scan, but financial constraints, we couldn't do that, and we are still waiting for it. So she's currently on phosphorus and active vitamin D supplementation, and she's only showing a marginal improvement in her symptoms. So this could be a case of tumor-induced osteomalacia, what we propose. So if it is still the same, we are planning to initiate her on sinac acid along with this, which may improve her phosphorus. So concluding this, I would like to tell it is a rare autosomal recessive skeletal condition, pycnodysostiosis per se, and this pycnodysostiosis has got increased bone density and increased propensity for fracture per se. But an association like an FGF23 mediated hypophosphatemia is not, to the best of our knowledge, it's not reported in literature ever, and this may be the first case to be reported ever.
Good. Rare case.
Okay, rare only. Yeah.
Yes. Okay. We'll proceed to next one.
Yes.
Thank you.
Next is that.
This was presenter number 10, no? In the list of judgment sheet.
Yes, sir.
Yes, yes. Okay. So how many presentations are done so far? 4 have been done.
5, sir. 5.
5 have been done. Okay, okay. Yeah.
Dr. Angad Kumar is online. No.
Anyone online pending?
Online, nobody else.
Nobody. So then they can.
Yeah. I will proceed.
Not you are also good.
Who is going next?
I'll be going next, sir.
Please start.
McCune-Albright syndrome. McCune-Albright syndrome.
Yes, go ahead. Go ahead. Finished? So may I please start?
Sorry, sir, I was muted. Am I audible, sir?
Yes, yes. Make it full screen, no? If possible.
Yes.
Yeah, please, your time starts now, please.
Okay, sir. McCune-Albright syndrome is a rare disorder of striking complexity with the prevalence of 1 in 100,000. So here we had a girl, an 8-year-old girl who was brought by her parents with a history of gradually progressive bowing of legs since 3 years of age, with also history of delayed motor milestones and history of delayed tooth eruption and multiple dental caries. And on further history taking, the mother gave a history of vaginal bleeding, which is of a single episode 6 months ago, along with gradual development of the breast since 6 months. There was no history of any fractures. On examination, she had a short stature with height age less than weight age, and her SMR was A1, P1, B4. She had stable vital signs. Head to foot examination revealed, as we can see in the picture, she had frontal bossing, she had prognathism, she had only the upper and lower incisors well developed, she had multiple enamel hypoplasia, and we can see the genu varum with an intercondylar distance of 19 centimeter. We can see the breast development at B4, and we can see the multiple cafe au lait macules, which are distributed predominantly on the right half of the body. So with these findings, we reached to a clinical diagnosis of McCune-Albright syndrome. And on evaluation, she was found to have a low phosphorus, and with a renal excretion of phosphorus with the TMP-GFR being low at 1.5, and she had elevated serum estradiol with suppressed gonadotropins. Thyroid functions were normal, and intact PTH was low. Ultrasound abdomen revealed the multiloculated ovarian cyst in the left ovary with multiple septations, and the uterus being in a post-pubertal size. So in the X-ray, we can see the ground glassing. We can see the genu, the varum, as well as the ground glassing on the lower end of the right tibia. And this picture shows the multiloculated cyst seen in the left ovary. So in this 8-year-old girl who presented with rickets, a clinical diagnosis of McCune-Albright syndrome was made in view of the features of precocious puberty in multiple cafe au lait macules as well. And she also had fibrous, polyostotic fibrous dysplasia. So since she had biochemical confirmation of renal phosphate wasting, it was diagnosed as a case of hypophosphatemic rickets, and she was started on phosphate supplementation 40 mg per kg per day after repleting vitamin D, along with calcitriol and calcium supplementation, and tab letrozole 2.5 mg once daily was started for the precocity. So this is actually a rare manifestation, and the characteristic profile is due to secretion of FGF23 from dysplastic bone lesions. So through this case, we want to highlight this rare presentation of hypophosphatemic rickets presenting in a case of McCune-Albright syndrome, on which only very few case reports have been published in literature. Thank you.
Okay.
What is the exact reason
So
for
precocious puberty presentation, no?
Sir,
Or she came with a bone presentation.
What is the exact reason for hypophosphatemia in this case?
Sir, the main mechanism postulated is the secretion of FGF23 from the fibrous dysplasia lesions. Sir. Another mechanism is that there is a increased phosphate excretion. There is a GS-alpha activation in the renal tubules that causes increased renal phosphate excretion. So these two are the mechanisms postulated for hypophosphatemia in McCune-Albright. But usually it doesn't happen because the excess FGF23 is degraded. But in some cases, it does not happen. So that is why it becomes rare in this.
Very interesting case. So I think you have presented quite well.
Any question from your end? One?
Yeah. Yeah, it's a good presentation. By my side, I think I have actually found that such a scenario, I think we should
Hello?
always look out for. So I think nothing from my side. I think I have learned from
Any question from your end?
Yes.
Achha. Please unmute. Unmute.
I can. Hello. Hello.
The TV is muted. TV is muted. Sorry, Mohan sir. We can't hear because there's a technical problem here.
Okay. Okay.
Yeah, now you can. Now you can.
Yeah. Good presentation. Nothing from my side. I think good. Nothing to add. You asked. You told everything.
Good.
Thank you, sir. Thank you.
Next one.
What is this? Next presentation, Dr. Srijan.
Who is going next? As per the order, the 4, 5, 6 are not presented.
Yes, sir. Yes, sir. They'll be presenting subsequently.
Are they here?
Yes, sir. They are physically present, actually, sir.
Okay. Yes, visible. You can make it full screen.
Good afternoon, sir. Is my screen visible?
Yes. Go ahead. It's okay.
Good afternoon, sir. I'm Dr. Sujana from
Studies
Usmania
of this
Medical College.
full screen now.
I'm going to present a case. We are report a case of 40-year-old lady who was
referred for uncontrolled diabetes mellitus from surgery. He had multiple abscesses over scrotum, perineum,
and cheek over the past 1 year and presented with rapid weight gain and difficulty
walking over 4 months. He also had chronic
low backache and he was hypertensive and he underwent cataract surgery in the right eye.
On further clinical history, it was found that he was taking prednisone 20 mg per day and NSAIDs for chronic low backache since 3 years. Clinical examination showed Cushing-induced stigmata, and the investigations I'll just briefly down below. Osteoporosis is a silent disease which develops less often in the men than in women. Because men have larger skeletons, their bone starts late
and progresses more slowly.
And they have no period of rapid hormone change and glucocorticoid-induced osteoporosis is the most common cause of secondary osteoporosis and is the first cause of
Osteoporosis before 50 years.
Here, our patient, he was a young 40-year-old male patient who presented with rapid weight gain and difficulty in walking over past 4 months. And he had complaints of abdominal striae,
fatigability, and chronic low backache since 3 years.
He was also
hypertensive since 2 to 3 years, and he had cataract surgery for the right eye. He had no personal or family history of fracture, and he is not a smoker or alcoholic.
And clinical examination revealed
he was obese. His height was 144,
his weight was 63, BMI was 30.43
kg per meter square. Waist circumference was 106 centimeters, and waist hip ratio was 1.16:1. And he had a cataract in the left eye with pseudophakia in the right eye.
He had acanthosis nigricans, and he had broad violaceous striae
of width around 1 to 2 centimeters distributed over abdomen, arms, and thighs with the tapering ends.
And he had
spinal tenderness in thoracolumbar region,
especially
T12 and L1 region. And central nervous system examination revealed low power of lower limbs. The power was 2/5, and rest of the examination was unremarkable.
The clinical pictures
here show moon facies
and centripetal obesity along with broad striae.
Investigations revealed hemoglobin of 10.2 grams per dl with lymphocytopenia and eosinopenia. And he had elevated sugars with fasting of 106 and post-lunch 192. And his HbA1c was 8.5.
He had hypercholesterolemia
with elevated triglycerides and renal parameters were normal.
His 25 hydroxy vitamin D was low, it was 12 nanograms, and calcium was also 8.2. and his X-ray pelvis has showed bilateral avian avascular necrosis of the femoral head, which has stage 2, stage 4 of Fragility staging, that is complete osteolysis
of the femoral head with subluxation.
And X-ray spine has
showed multiple wedge compressions at T12 and L1.
With this,
we have subjected him to BMD, and his T-score was
minus 2.7 at femoral neck and minus 3.3 at vertebrae, and Z-score was minus
2.1.
Suspecting exogenous Cushing syndrome, we have sent in for 8 AM serum cortisol. It was found to be low, that is 2.21. And the clinical pictures here show bilateral avascular necrosis
and wedge compression at T12 and L1.
The final diagnosis
in this case was exogenous Cushing syndrome with severe osteoporosis,
bilateral avascular necrosis of the femoral head with secondary diabetes and hypertension. The patient was treated with calcium and vitamin D supplements, and also anti-resorptive therapy was planned
after initiating on teriparatide. He has been administered teriparatide
20 micrograms for a period of 6 months, and he is under follow-up. Anti-resorptive therapy is planned. So, the history of steroid intake should be considered in any patient who presents with Cushing-like features, and assessment of bone health is very important. It depends upon the rate of bone loss depends on dose and duration of the steroid used. And this patient can be managed with arthroplasty at a later stage after
giving bisphosphonates for his bone loss.
Yeah, good presentation. So I think the presentation is classic also. I think very classic presentation also. So picked up quite early.
Mohan, any question from your end?
No. My side nothing. It's actually classic.
See, straightforward. Okay. Okay, nice presentation. We'll move on to the next.
Dr. Manoj Kumar will be presenting, sir.
Okay.
Number 7, no? Number 7. Yeah. Presenter number 7. Yeah. Please go ahead.
Good evening, sir. So today I am going to present about a rare unusual presenting feature of a primary hyperparathyroidism. So bilateral slipped capital femoral epiphysis as an unusual presenting feature of primary hyperparathyroidism in an adolescent. So primary hyperparathyroidism is very rare in adolescent age group. Bilateral slipped capital femoral epiphysis is quite common in obese children when they are in adults in pubertal stage. But occurrence of association of bilateral slipped capital femoral epiphysis in primary hyperparathyroidism is very rare. And till now there are only 15 cases documented in English literature. So 14-year-old girl presented to us with presenting complaints of diffuse bone pains and difficulty in getting up from sitting position and with waddling gait. She attained her menarche at 12 years of age, and her body mass index is 20.17 kg per meter square. So, in view of her waddling gait and proximal myopathy, we did a X-ray hip joint, which revealed bilateral loss of clean line and bilateral slipped capital femoral epiphysis. And X-ray hand was showing hypoxia, and X-ray chest APV suggested subchondral resorption along the acromioclavicular joint. So, in view of the bone resorption changes in chest X-ray APV on hand, along with the bilateral SCFE in X-ray, we did a literature review, and we found out that primary hyperparathyroidism can present in adolescent age group with bilateral slipped capital femoral epiphysis. So, biochemical investigations showed serum calcium of 11.8 mg per dl, and inorganic phosphorus of 3 mg per dl, and the parathyroid hormone of 2,797 picogram per ml, and alkaline phosphorus of 4,784 units per liter, and 25 hydroxy vitamin D level of 4.7 nanogram per ml, and serum creatinine of 0.4 mg per dl. So, in view of biochemical confirmation, we did a systematic parathyroid scan, which revealed, along with the CT scan, which revealed 1.7 into 1.7 to 2.4 centimeter left inferior parathyroid adenoma. She underwent excision of the parathyroid adenoma, and on a later date, we planned for bilateral infiltration of hip joint. So, coming to the pathogenesis of slipped capital femoral epiphysis in adolescent age group, during the growth spurt, there will be undue pressure on the epiphyseal cartilage. So in primary hyperparathyroidism, there won't be a mineralization of the epiphyseal cartilage, and epiphyseal cartilage won't be fused. So if you have the rapid proliferation of epiphyseal cartilage, there can be a slipping of the femoral epiphysis in the presence of primary hyperparathyroidism. So conclusion, although unusual, in prepubertal and pubertal children with bilateral capital femoral epiphysis, hyperparathyroidism should be ruled out, as initially it will be a sole presentation as is in this index case, and early identification will prevent the complications like osteoarthritis. And during literature review, we found out that whenever slipping capital femoral epiphysis is associated with hyperparathyroidism, the extent of hyperparathyroidism was very severe in them. So denoting high parathyroid hormone levels and high alkaline phosphatase levels. Thank you, sir.
Nice.
A good presentation. No, you have quoted one reference from our part of the, from Dr. Jabbar sir and group. So that's one thing I am noticing.
Yes.
So presentation is quite excellent, and I think you have covered it. I think the question to ask only regarding how commonly you just miss this condition. How many cases have you actually seen?
This is the second case in a span of 6 months which we saw in OPDs.
Yeah, so it's because of the
usually bilateral capital femoral epiphysis associated with endocrinopathy is only 5 to 7%, sir. In that thing, severe hyperparathyroidism is very rare. General common causes are hypothyroidism and hypopituitarism.
Yeah.
So severe hyperparathyroidism occurring with bilateral SCFP is a very rare cause.
So how does phosphorus help in this regard? How does the phosphorus measurement help in this case?
Yes, sir. Surprisingly, phosphorus was the lowest in the normal side in this girl, sir. But post-operatively, she had hungry bone syndrome, sir. We anticipated hungry bone syndrome because in view of high ALP levels. So she is still in the phase of hungry bone syndrome. So we are planning fixation at the later days. Initially, we planned fixation and parathyroidization at the same similar setting, or in a span of 1 or 2 days. But she went into hungry bone syndrome. So we delayed that bilateral fixation of hip joint to later date. So right now she has been on 4 months of calcium supplements.
Yeah. So okay, well done. Next presenter, please. Thank you.
Thank you.
Three more presenters are left. Sumaya.
Next, Dr. Anis will be presenting.
Yes, visible.
Good afternoon, respected teachers. I will be presenting on vanishing bone disease, a rare disorder which is characterized by spontaneous bone resorption of multiple skeletal sites. This is a 22-year-old male who presented with dull aching pain over the left upper back following a sudden activity. There was no fever, trauma, or weight loss. On examination, he was found to have, he was a tall stature. He had significant hollowing of the left paraspinal area. Vital and systemic examinations were normal. On evaluation, his biochemical investigation, including calcium, phosphorus, vitamin D, were normal, and his alkaline phosphatase also were normal because prior to presenting to us, he has received bisphosphonates. His bone turnover markers were also normal. X-ray of the affected area showed the figure 1 is showing mixing ribs in 4 to 6 in the left hemithorax, and reconstructed CT was showing a light lesion of the rib in the 4 to 6 rib in the left hemithorax. So based on these findings, radiological and clinical findings, we have made a diagnosis of vanishing bone disease, which was confirmed on a CT imaging. Biopsy was not performed because of the precarious location of the disease, and the biopsy was performed thoracic duct leak and could have been a complication. That's why it was not performed. And this is a rare disease. etiology is uncertain. Local hypoxia, increased VEGF activity were the proposed mechanisms. Treatment includes surgery, radiotherapy, medications are bisphosphonates, interferon alpha, and VEGF inhibitors like bevacizumab, propranolol, and sirolimus also have been tried. All these are case reports. And in our patients, we have given IV solanolate once a month for 3 months, then once every 3 months for 2 years. He also received interferon alpha, initially thrice a week, followed by once in every 10 days. And on follow-up, constant follow-up, we found that he had a stable disease with no radiological progression over the 2 years. And this is in concluding. So far, only 300 case reports are found in the literature. High index of suspicion for diagnosis after excluding common infections, inflammation, and other neoplastic condition should be. This has to be kept in mind, and combine treatment with approach with close monitoring and close follow-up is required.
How common it is?
It is a very rare disease. It is only 300 case reports are there so far. More than the diagnosis, the treatment is very challenging. So there is no published data on how to go about it. It's all case reports.
Genetics, is there anything?
Sorry, sir.
Is genetics having any role in this?
We have, sir, genetics. We have not done genetics. This is, if you look at the osteolytic lesion, there are 5 types. This is type 4. There is a, for diagnosis, there is something called HEFAS criteria, which has a clinical, radiological, and pathological category, but genetics per se is not help in diagnosis. But if you look at the osteolytic lesions, there are 5 types. Type 1 is the hereditary osteolytic syndrome, which is autosomal dominant, and type B is autosomal recessive, and type 3, which is associated with nephropathy, and this is type 4 osteolytic syndrome.
Okay.
Oh, good.
Good. Okay.
Nice presentation.
Any more left? One more is there. Can Sumaya help? How many people are left now? IT team? Are we done? Any more presenters? 4 o'clock is already so.
Dr. Amjad actually, he just logged in now. He's asking if we can present.
Presenter number 5, utility of anthropometric indicators.
Dr. Kushal is presenting, sir.
Can you hear me? Yeah. Yes, please go ahead.
Good evening, all.
make it?
Can you make it 0? Good evening all. My name is Cushing-Induced and I'll be presenting the study on utility of anthropometric indicators in predicting osteoporosis in ambulant community dwelling rural postmenopausal women from southern India. As we all know that osteoporosis is a major public health problem. The prevalence of osteoporosis in South India is estimated to be anywhere between 35 to 50%. The diagnosis of osteoporosis is made based mainly on bone mineral density as evaluated by DEXA, but its cost and availability remain a concern. So, multiple studies have proven that bone mineral density correlates with multiple anthropometric measures like weight, waist circumference, hip circumference, and neck circumference. So this formed the basis of the study. The aim was to correlate which of the anthropometric measures can be used as a screening tool first, and also as we all know that the anthropometric measures have a ethnic component. So to find out the normative data for our Indian population. So this was a cross-sectional study in postmenopausal women above the age of 50 years, which were recruited from the community. Any disease like chronic kidney disease or chronic liver disease, malignancy, anybody on treatment for bone, already on treatment for calcium supplements or with a diagnosis of osteoporosis were included. There were anthropometric measures were taken and DEXA was done. The reference was Indian Society of Clinical Densitometry Criteria with osteoporosis defined as T-score less than -2.5. The sample size was calculated based on a previous study and a total of 315 number was derived at. And of 308 subjects, 91 had osteoporosis at the neck of femur and 125 had osteoporosis at lumbar spine. The significant finding, as you can find over here, is that the correlation, there was a significant correlation with weight, BMI, neck, waist circumference, and hip circumference, and all of these values were significant with a p-value of less than 0.001. And there was a correlation with age that is kind of expected. We also derived the sensitivity and specificity data using multivariate logistic regression, and we found that the neck of femur, age and weight were significant, while at lumbar spine, weight and waist circumference were significant. So the association is not linear. With the association of BMI and fracture risk, it is not linear. The risk increases significantly at BMI less than BMI less than 22. At higher BMI, there is a risk of forearm fracture, and at lower BMI, there is increased risk of hip fracture. The National Health Education and the NHALS survey also found that various obesity measures and BMD have strong correlation, which was more significant at neck of femur. And to conclude my study, this study showed that anthropometric measures like weight, waist circumference, hip circumference, and neck circumference have independent positive correlation with BMD. And they may serve as a surrogate marker. They cannot replace BMD, but they can be used as a screening tool at the community level, especially in the rural setting, to screen the high-risk population, especially postmenopausal or postmenopausal women or people with other risk factor for osteoporosis, to select the group of people who may undergo DEXA at a higher center. The strengths of the study were that it was the first Indian study to analyze all the anthropometric measures. It's cost-effective, easy, and it's easily reproducible. It is not skill dependent on the technician like we studied today morning. The DEXA is technician dependent, and it can be easily carried out in a resource-limited setting. The limitations were it was a cross-sectional study and involved only the rural population, which is a healthier population, so they may not be enough to derive the normative data. And we calculated the osteoporosis risk only at a single point for
they need to be calculated at multiple points for the value to be significant. Thank you.
What is the vitamin D status?
Sir, any question from your end? Mohan?
Vitamin D status. Question regarding vitamin D status. Have you done that?
Vitamin D.
Sorry, sir?
Have you done any data on vitamin D?
Not in this study, sir. Vitamin D levels were not studied in this study, sir.
So you have done only the community-wise survey, no? You have not done any.
We have studied in different. This was a community-based study, so vitamin D levels were not studied.
Okay, okay. But how is the area having vitamin D sufficiency, or do you have any population-wise any data on that in this population or remaining similar population?
I can't.
Because you are screening high risk, no, people. So, what is your inference? Will vitamin D affect this also?
Can you increase the volume?
Okay, I cannot tell more than this. Okay. Vitamin D status, whether it will be helpful in this case, and if yes, how is this in your population?
Vitamin D status definitely affects the osteoporosis, because we have also previously seen in various other studies that low vitamin D will result in osteomalacia, which can have a significant overlap with the osteoporosis. One. Second is we have found that in our previous studies that the population, the rural population has relatively higher vitamin D levels compared to the urban population. This population might have had normal vitamin D levels because this was a rural community.
Okay. There is some study by some Harinarayan sir on vitamin D. Maybe you can go through it later on. Okay.
Sure, sir.
Yes. We'll move on to the next one.
Last presenter, no? Last presenter. Losartan as steroid sparing agent. Is it? Yeah. Losartan.
So, good evening again. Can you mute it, sir?
I'm very bad.
Camurati-Engelmann syndrome. It's a fairly rare disorder. It has only 300 cases being reported worldwide. The first case was reported in 1920. And this disease is characterized by bone pain, waggling gait, and easy fatigability. And it is caused by an autosomal dominant missense gain of function mutation in transforming growth factor beta 1. The treatment options include bisphosphonates, steroids, and angiotensin receptor blockers like losartan have been tried. So what we present is a case of 27-year-old female with instantaneous onset progressive pain in both her legs and arms since last 6 months. There was no family history of fracture, renal pain, renal stones or joint pain. Hearing and eyes were normal. On her examination, she was short stature with a height of 144 centimeter, and there was tenderness in both thighs and waggling gait. There was no facial dysformism, macrocephaly or cranial nerve involvement, sclera and dentation were all normal. Active and passive joint movements were all normal with no restriction. Since everything, since her initial clinical evaluation was normal, her X-rays done which showed diphysial dysplasia seen in the X-ray. The diphysial dysplasia was not just limited to long bones, but also seen in the skull. So she underwent a bone scan which showed super scan increased uptake in multiple long bones. Initial biochemical workup, we can see that alkaline phosphatase was raised. So she was with this the clinical diagnosis of diphysial dysplasia of Camurati-Engelmann syndrome was made, and she was started on steroids 0.5 milligram, and this was continued for the next 6 months. The pain had decreased significantly, but unfortunately she developed exogenous Cushing-induced features. And in an effort to taper off the steroids, she was started on oral bisphosphonate, but that did not help much. So a quick literature review search was done, and there were a few case reports which showed benefit on addition of losartan, which was added. So this was the biochemical evaluation at clinic. At the presentation, which had not decreased much after starting steroids, but as you can see, after starting losartan, the values had come down significantly. The alkaline phosphatase is not raised in all of the cases, but has been used as a surrogate biochemical marker in multiple cases. To conclude, I would just like to say that this is a fairly rare disorder, and the steroids remain the mainstay of treatment. But if somebody develops intolerance to steroids or has exogenous Cushing-induced manifestations, and there is no improvement on oral or IV bisphosphonate, then losartan should be considered in such patients. Thank you.
What is the exact mechanism? How it is helpful in this?
So the pathogenesis of the disease is that there is a gain of function mutation of transforming growth factor beta. It activates the osteoblast and inhibits the osteoclast, which affects the remodeling. So losartan has an effect on transforming growth factor beta, and this is where the action actually happens. There are conflicting case reports regarding the use of losartan in these patients, but our patient had a significant improvement, and she continues to remain in our follow-up, and she's on losartan 25 milligram. There was no hypertension on losartan, and she had improvement.
Why specifically losartan? There are many other ACE blockers, no, angiotensin 2 blocker. Why specifically losartan is there mentioned in literature, or you have any reason for that?
No, so the losartan was the only one that was mentioned in the literature, and this is the only this action of losartan is not because of its angiotensin receptor blockage. It is an action because it has an action transforming growth factor beta 1. So this was the action that was used for this.
Understood. Understood. Okay.
Yes, thank you.
Thank you.
Thank you, Sudhakar sir and Rohan sir. We have finished the first hour slot. Thank you so much.
Okay.
Now we'll go on to the next hour slot. That will be presentation by faculty as well as research fellows. So we have 3 judges. We have Professor Marwaha sir, Professor Usha Sriram ma'am, and Professor Maithili ma'am. So shall we start, sir, ma'am? Yes.
Reduce that. Reduce
This is
0.
Hi, Maithili.
Presenting.
Hi.
So, shall we start? Dr. Rimesh Pal, sir, are you ready, sir?
Yeah, good evening. Good evening, ma'am. Yeah. Should I go ahead?
Please.
Yeah, thank you, ma'am. I will just share my screen, ma'am. Ma'am, is my screen visible?
Yes.
Yes, I will just project in a slideshow mode, ma'am. Yeah. Is it visible, ma'am?
Yes, visible. Yes.
Okay. Right, ma'am. So, ma'am, I will straight away go ahead. So I'm Dr. Ramesh. I'm working as assistant professor in the Department of Endocrinology at PGI under the mentorship of Professor Badada. So I will be presenting this first case. So it is just a case report of a very common disease, but with a relatively uncommon presentation. So we had encountered this. So I'll be presenting a case of PJ disease who had been presenting with a waxing waning kind of a serum calcium level, or what we call it as a recurrent hungry bone syndrome in a patient of polyostotic Paget disease of bone. So basically, as we all know, Paget disease of bone is one of the rare metabolic bone disease. In India, it is more common in the southern part of the country. Most of the cases remain asymptomatic and rather picked up while being walked up for for unexplained elevated serum ALP level. In fact, elevated serum ALP level is the most common biochemical abnormality in this disease entity, and serum calcium and phosphate levels usually remains normal. So in this lady, in the index case, she was an 81-year-old lady who had presented in 2019 June with generalized body ache, and it was so severe that she was unable to walk for the past 1 month. She was wheelchair bound for the past 1 month. So she had her past history was significant in that she had sustained fragility fracture of the left wrist and right forearm following a trivial fall actually in the washroom 1 year back. At presentation, on investigation, she was found to have hypercalcemia. Corrected calcium was as high as 12.4. Her phosphate level was also marginally elevated at 4.6. ALP levels were elevated at 433. PTH was suppressed. Her vitamin D levels were 36 nanogram per ml. She was vitamin D sufficient, and her bone turnover markers, UNNP and CTX, were also proportionately elevated. So she fit into the picture of a PTH independent hypercalcemia. We got X-rays done, which are not being projected here because of lack of space. We got a skeletal survey done, or a metabolic bone survey done, which revealed mixed lightly sclerotic areas predominantly in the skull and the humerus and femur. Subsequently, we got a bone scan done, which showed areas of hypermetabolism in the corresponding areas, that is skull and long bones. We got a FDG done so as to rule out any malignancy at this age presenting as PTH independent hypercalcemia. So FDG scan didn't reveal any other hypermetabolic areas. Probably malignancy was somewhat ruled out. So we labeled her as having a Paget disease of bone with PTH independent hypercalcemia, which was because of the massive increase in bone turnover, which is per se rarely described in Paget disease. Now the next rarity. So basically, we offered the patient the option of zoledronic acid versus denosumab. The patient's attendant were a bit apprehensive about zoledronic. Since they were pretty educated actually, and they went into literature and they said that they wanted us to go ahead with denosumab. We administered a 60 mg dose of denosumab subcutaneously, and within 1 week, 7 days, her calcium fell down to 8.5 and phosphate to 2.4. Even she had symptoms of hypocalcemia. Perioral paresthesias, and basically she had symptoms of hypocalcemia as well. So this was attributed to the hungry bone syndrome. It is rarely described in Paget disease. So when we administer denosumab, it causes stunning of the osteoclast, but the osteoblasts continue to function for some point of time. So the use of the calcium, this leads to a hungry bone kind of picture. So, but within 1 month, we saw that calcium and phosphate levels normalized, her bony pains reduced, and she was able to walk on her own. But again, after 5 months, the same symptoms recurred. We again investigated her, again found that her serum calcium and phosphate levels and ALP levels were elevated. We again gave a second dose of denosumab. She again had an episode of hypocalcemia with spontaneous normalization. So till September this year, we have injected her with 6 doses of denosumab, and following each and every dose, she has shown a similar picture preceded by hypercalcemia, succeeded by hypocalcemia, as we can see in this picture. So the first dose was given somewhere in July 19, second in January 20, third in July 20, fourth in December 20. After the fourth dose, in fact, the frequency of denosumab had to be increased. Rather, she started having symptoms even after 3 to 4 months. So the fifth dose was given at a gap of 5 months, and the last dose in September was given at a gap of only 4 months. So this is the picture. We find that before she presents with hypercalcemia, lands up in hypocalcemia, and this cycle continues. So In conclusion, this is definitely the first step, and to the best of my knowledge, and to the best of, I mean, definitely this is the first case of Paget's presenting as hypercalcemia as well as hungry bone syndrome in the same patient. Hypercalcemia could have occurred because of increased bone turnover, which is rarely described, and hypocalcemia would have occurred because of hungry bone syndrome, because of transient stunning of the osteoclast, while the osteoblasts continue to function, leading to a state of transient hungry bone syndrome and hypocalcemia. Then subsequent plan would be to administer him with zoledronate, because we believe that zoledronic acid will lead to a state of, basically will lead to osteoclast apoptosis and probably prevent this rapid fluctuation in serum calcium. So this would be our subsequent plan. We will convince the patient somehow to go ahead with zoledronate. That's all, ma'am.
Yeah, Raman, you have a question.
Why didn't you think of doing bone markers every time?
Yeah, bone markers were elevated, sir. We have done, sir. I haven't presented it here. Bone markers, basically bone markers go exactly hand in hand with serum calcium and ALP. Basically, when she presents with hypercalcemia, ALP and bone markers are elevated. P1NP and CTX. The moment she lands up in hypocalcemia, her basically the initial phase of hungry bone syndrome is characterized by ALP levels remain practically normal. Subsequently, over a period of 1 to 2 months, ALP and calcium and P1NP CTX levels decline. So it shows basically the bone markers go exactly hand in hand with the serum calcium.
What other workup have you done for the hypercalcemia?
Ma'am, the first possibility was a malignancy at this stage. Multiple myeloma has been ruled out. We have done a serum electrophoresis, which is normal. Even her biochemistry does not show AG reversal. And we also kept the possibility of some other underlying malignancies with bone metastasis. We got a PET scan done, which is not showing any evidence of hypermetabolism anywhere. The first possibility of a myeloma followed by malignancy, I think we have confidently ruled out both of them. At this age, ma'am, 81-year-old at this age.
Does denosumab produce hypocalcemia?
Denosumab produces hypocalcemia, especially when it is administered in stage 5 CKD. As such, denosumab does not lead to hypocalcemia. In the freedom trial, a few patients where denosumab were given in a stage 5 CKD, they did experience transient hypocalcemia, but otherwise denosumab do not cause hypocalcemia.
Okay. Thank you so much.
Thank you, ma'am.
Yeah. Go ahead with your next presentation, sir.
Yes, ma'am. I will just share my screen as well.
Yes, sir. So please stick on to the time, sir. It's already 6 minutes that your presentation is done.
Okay, ma'am. I apologize.
Please start.
Yeah, I'm just sharing my screen in a second. Yeah, it's almost there. I hope my screen is visible, ma'am. Yes, ma'am. So this is a community-based study, prevalence and pattern of self-reported fragility fractures in the community, a cross-sectional survey that was undertaken under the aegis of the FLS services that were being carried out in Chandigarh. So I will start with the saying that population-based prevalence of fragility data on the community prevalence of fragility fracture in India is not so common. We have the ISBMR INDIAP study that had assimilated data of around 52,000 patients, the subjects, I would say, and had reported a self-reported fracture of 2.6%. And other than that, population-based studies are almost not there. Most of the studies are hospital-based studies. Again, we do have a Delhi-based study, the DeVos study. That was also, I should not say, a population-based study. It was more of a population-based study, but it was not a door-to-door survey. It was more of a camp-based study. So, considering all these limitations in mind, supported by the FLS, under the aegis of FLS, we carried out a population-based survey in Chandigarh. It was a door-to-door survey that was conducted from Jan 18 to December 29 over a period of 2 years. 6 sectors were chosen in Chandigarh by simple random sampling, and houses within each sector were chosen subsequently by systematic random sampling. Like houses ending with either 5 or 9 were 5 or 9 were subsequently chosen. All household members within that chosen house, aged more than 40 years, were eligible for inclusion. It was just a questionnaire-based survey. We inquired about whether they had any history of fragility fracture, and whether they're having any common comorbidities like diabetes mellitus. Common comorbidities were noted down. And fractures that had occurred in relation to a road traffic accident or high force trauma were labeled as traumatic fractures and subsequently were not noted down. We had interest in only fragility fractures. So over this period of 2 years, after having surveyed through 6 sectors, we recruited 4,285 community dwelling subjects. Mean age was somewhere around 56.2 years. It was almost equally, almost 51% were women, 49% men. About 13% of the population had diabetes mellitus. Again, I should specify that it was a self-reported diabetes mellitus. Patients who told they had diabetes and were on medications were labeled as having diabetes mellitus. The prevalence of self-reported fragility fracture in this population of 4,285 patients were 3.6%. It was higher than the ICMR INDIAB study. And the most common site of fragility fracture as shown in table 1. It was a lower limb. By lower limb, I mean fractures below the hip. I mean, because hip fractures constituted about 20% of the cases, and lower limb fractures like fracture shaft femur, fracture tibia, they constituted about 35.6% of the fractures. Wrist fractures were second at about 28%. Vertebral fractures were also reported vertebral fractures, not morphometric, that was about 2%. And for subjects with fractures expectantly were older. As we can see in figure 1, they had a mean age of 58.7 years versus 56.1 years, and they were more likely to be females. The prevalence of fractures in female was 4.3 versus 2.8 in males. However, what strikingly we found that there was no difference in fracture prevalence between those with and without diabetes. Numerically, there was a difference, but statistically, there was no difference. So ultimately, we conclude that in this community of North Indian adults, we found a fracture prevalence of 3.6%. Fractures were expectedly more common in women than in men. However, we didn't find any difference in fractures between those with and without diabetes, and probably larger studies are required. And probably this data would help subsequently develop programs for the prevention and management of fragility practice in the country. Thank you.
Thank you. I have 2 questions. Among the diabetes, were you able to break it down into male and female? Because the INDIAB also showed fractures only.
Yes, ma'am. As I remember, they found a difference only in female, not in male. In the INDIAB study, right, ma'am? If I'm not wrong.
Yeah, correct. But not in
I will have to go through it, ma'am. I have the data. I can reanalyze.
Yeah,
I didn't do it. I agree,
to go through it to see whether INDIAB is a one-off thing or is that a pattern.
Right.
And also, were any of your patients on osteoporosis treatment?
No, ma'am. We had omitted patients who had we had omitted patients who had been on osteoporosis treatment. Absolutely, ma'am. Hello, ma'am.
What is the reason for women to have more fractures? In fact, it should have been the other way around. But men who work physically more, they're likely to have more fractures. What do you think is the cause in your case?
Women per se, ma'am, postmenopausal. The age is typically a postmenopausal age. The mean age of the study we recruited. Probably that could have been the reason.
But it is both men and women of the same age?
Above 40.
No, I mean.
Yeah, 40. And there were no significant difference in the age between men and women, as I've already said. The mean age of the population was around 56, which was almost similar between the two.
Yeah, the morphometric fractures also, which was done, was a population study from different regions of Delhi. You know, they were all people who used to meet in the old age hall in Delhi.
Yes, ma'am.
Some kind of healthy patient. So it was also kind of a community kind of a.
Okay, sir.
It was not that these were the people staying in that community. They used to meet in the common hall of their community.
Okay. Right, sir. Agreed.
Okay, thank you.
Thank you, ma'am. Thank you, sir. Thank you.
Buddharaju, please join. Dr. P. Buddharaju. Dr. Buddharaju. Dr. Swati Rajput.
Yes, ma'am. I'm sharing my screen. Just hello, good evening, everyone. I'm Swati Rajput. Today, I will be presenting this poster entitled as "A collagen domain-derived short adiponectin peptide has osteoanabolic effect by mitochondrial resetting and metabolic reprogramming in osteoblasts." In our previous study, we found that globular adiponectin has osteoanabolic effect and it completely reverses the OVX-induced bone loss. So, because globular adiponectin is a large protein, because of its size, it is difficult to use as a drug. So recently we have discovered a short adiponectin peptide, which is around 13 amino acid long, and it has its effect in the glucose and fatty acid metabolism. So here we are checking the effect of ADP1 in osteoblast cells. In our first experiment, we have checked the effect of ADP1 in osteoblast differentiation and found that it significantly increases the alkaline phosphatase activity, which is the early differentiation marker of osteoblast, and as well as mineralized bone nodule formation. As we know, osteoblast differentiation is an energy demanding process. So next we checked its effect on the osteoblast bioenergetics and found that it has no effect on glycolysis, but it increases the oxygen consumption rate, which characterized by increase in basal respiration and maximal respiration and enhanced ATP production. Further, rotenone, which is a mitochondrial respiration inhibitors, but not 2-DG, which is a glycolysis inhibitors, completely block the ADP1 induced stimulation of ALP activity. Moreover, we found that it also increases the mitochondrial membrane potential, which we have checked by measuring the intensity of mitotracker rat CMX toss. In the next study, as we know, TCA cycle is a major energy yielding metabolic process in cells. So we have checked its effect on the intermediates of TCA cycle. So we found that there is an increase in consumption of alpha ketoglutarate, which leads to increase in glutamate utilization, which is one of the source of ATP production, for which osteoblast cells use for its differentiation. Moreover, it also stimulated the cellular energy sensor, phospho-AMPK, which also support our hypothesis that it increases the ATP production, which cells are using for differentiation. After in vitro, we have checked its effect in the in vivo. For in vivo, we use two concentrations, 12.5 microgram per kg and 25 microgram per kg. For this, we have overcomized the female rats and left for 3 months to develop osteopenia. And after 3 months, rats were treated with 2 different concentration of adiponectin peptide, and we found that there is the trabecular bones were restored in femur and tibia in the 25 microgram per kg dose, which is characterized by increase in BBTB, trabecular number, and trabecular thickness, whereas the trabecular spacing is decreased in adiponectin 25 microgram per kg dose. Here, PTH we use as a positive control. Moreover, it also reduces the OVX-induced increase in fat mass, as well as increase in the glucose tolerance. So with this study, we concluded that ADP1 stimulates osteoblast differentiation and bone nodule formation by stimulating mitochondrial activity such as mitochondrial membrane potential, ATP production, maximal and basal respiration, as well as it stimulates the glutamate utilization to fuel the energy machinery required for osteoblast differentiation, as well as it restores the trabecular bones in aged OVX rats, which is the model for osteoporosis, and it also reduce the increase in body weight by reducing fat mass and improve glucose tolerance. Thank you.
Your conclusion. Show your conclusion.
So ADP1 is a small molecule, so it can be used as a drug. So because it has osteogenic activity.
Your
conclusion. Yeah.
So my first question is, how does ATP1, how do you conclude that it mitigates induced increase in body weight by reducing fat mass and improve glucose tolerance? How did you come to that conclusion?
I'm not getting, sir. Can you just repeat your question?
Last conclusion, ADP1 mitigates the overexercise induced increase in body weight by reducing
fat mass.
And fat mass, by reducing fat mass.
Fat mass. And it also improves glucose tolerance.
How does that increase body weight?
Because the in OVX that adipogenesis is increases, so the OVX rats has higher body weight, which is because of the increase in fat. And in our study, this adiponectin decreases that increase in fat mass, and because I'm not showing here body weight, that is why that body weight is also decreased.
Body weight, how do you conclude that? And secondly, tell me, how would you apply a dose in terms of, in mice you said 25 microgram is effective, right?
Yes, sir. 25 microgram per kg is effective.
Not what is the other dose?
12.5. We have used two doses, 12.5 and 25.
How do you relate this in terms if you have to apply this to human beings?
In that,
how did you come to decide on these doses before you started this?
We have checked these doses in newborn pups, and we have checked the effect of this peptide on the expression of osteogenic genes. In newborn pups, we have used these doses, and there we found that 12.5 and 25 microgram per kg has effective doses, and it increases the expression of osteogenic genes. That is why we have used here these two doses.
So how would it relate to human beings, your experiment, if you say that this improves your osteoblastic activity?
Yes, sir. Because this dose is for rat, we can convert it to human and then we can use.
If on this basis of this experiment, you feel strongly that this will be...
No. Some experiments are lab. This is not the complete study. Here we have to check PINP, CTX levels and calcium labeling. Some more experiments are left, so we have to do that.
Thank you so much, Swati. Okay.
Dr. P. Verma, please share your screen.
Hello, madam.
Yeah, you're audible. Please share your screen.
Yeah, my screen is visible, madam?
Yeah, visible. Yeah.
Uh, Good afternoon, madam and sir. Dr. Verma, Assistant Professor in Department of Endocrinology, SWIMS, Tirupati. I'm presenting a case of prolonged hungry bone syndrome in a post-op case of parathyroid adenoma. We all know that hungry bone syndrome is a complication happens after surgery for parathyroid and primary hyperparathyroidism, also seen in some cases of hyperthyroidism also after thyroidectomy. But this hungry bone generally recovers within a weeks to months. Usually within 3 months, but in some cases it may take many months to 2 years also. So this is presenting that kind of a case. 39-year-old presented with history of fracture humerus and clavicle on trivial trauma. She fell down from a bed one night and she sustained the fractures. Then she went to orthopedician. Then he treated her primarily and then referred here for further evaluation. She has no history of steroid abuse, no thyrotoxic symptoms, no history of weight gain or striae, no history of abdominal pain or no history of recurrent renal stones. On evaluation, biochemical evaluation showed calcium of 60 and albumin of 3.4 and phosphorus normal, creatinine normal, alkaline phosphatase is surprisingly normal. And PTH levels were very high, 2,382, and the TSH was 40. Initially, for maybe 3 years ago, she was told to have a low thyroid and advised replacement, but she used for 2 weeks and stopped 3 years back only. With that background, she was having TSH of 40 and vitamin D levels were normal. BMD showed osteoporosis and JET score of -3.2. And USG neck and the technician scan was done. It showed left inferior parathyroid adenoma. Because she's 39-year-old, we did a prolactin 24-hour urinary fractionated metanephrin to rule out Men's syndrome, and it was normal. And the system AB scan showed a left inferior parathyroid adenoma. So we referred this case for surgical management, and she was operated for left inferior parathyroidectomy. And during surgery, we demonstrated a 90% drop in intraoperative PTH. So surgery was successful. Then on post-op day 3, she started developing hungry bone syndrome with drop in calcium levels and phosphorus levels. At this point of time, alkaline phosphatase levels were elevated. From before, at the time of presentation was 90. And after this case was operated 10 days after admission. During these 10 days, we replaced her with thyroxine supplements because she was having frank hypothyroidism. So after that, she alkaline phosphatase started rising. So we labeled her as hungry bone syndrome. And but we initially given a calcium replacement orally, then tried, but she was having spontaneous Rosary positive. So we started on IV replacement. And with IV, she required that IV replacement nearly for 3 weeks. She was in ICU for that long, and also we replaced the magnesium also. And she phosphorus has dropped to 9.8. So we started on phosphorus replacements. Now, and after that, she stabilized after 3 weeks, then discharged. Now, even after we are following her on monthly basis, but even after 8 months also, she's still requiring oral calcium, and we are giving calcitriol 0.25 BD. Micrograms, and now still she requiring calcium 3 grams per day to maintain normal calcemia. So still she is not completely recovered from hungry bone syndrome. So to conclude, this is a hungry bone syndrome. We commonly know that complication of parathyroid adenoma surgery, but many cases usually recover from within weeks to months. But a few cases may take more than 6 months or up to 1 year also. That depends upon the degree of bone loss, how late they present, how severity of bone loss they have before surgery. So that's why these patients require frequent and long-term follow-up. And why this patient has a normal alkaline phosphatase, then we searched in the literature, madam. And because before surgery, though PTH levels are elevated, alkaline phosphatase is 90. In some cases of overt hypothyroidism and severe anemia, these cases can have a normal alkaline phosphatase despite elevated PTH levels. So that could be the reason. So we corrected that hypothyroidism over 10 days, maybe after replacement. That's why, and on top of that, she developed hungry bone syndrome. That's why she might have developed, documented elevated alkaline phosphatase during hungry bone period. Thank you.
One thing, why didn't you correct hypothyroidism before surgery?
Sorry, sir.
That
10
is
days
very obvious. Why
Yes.
didn't you correct? Otherwise, your alkaline phosphatase would have been high.
Yes, sir. We corrected for 10 days, sir. We are given thyroxine supplement. Sorry.
Was it
Sorry,
before surgery or after surgery?
Before surgery, 10 days we are given, sir. because this workup and took 10 days.
Well,
And
you don't expect it to come up. No?
sorry, sir. That's why, madam. And after surgery started rising up. Alkaline phosphate started rising up after surgery.
So we are calling this hungry bone and versus, are we sure that the parathyroids are intact?
Yes, other three, because phosphorus is also on the lower side, madam. It went up to 0.8. So she, for 3 weeks, almost 3 weeks, she required oral phosphorus also because it dropped to below 1.
Can you get a similar situation in any other endocrine organ?
Yes, vitamin D deficiency after treating with the vitamin D replacement they can get, and also hyperthyroidism patients after thyroidectomy they can get.
Get what?
Hungry bone.
Hungry bone, hungry bone.
No. I'm saying suppression. You see, you operated on this parathyroid adenoma.
Yes.
That parathyroid adenoma had suppressed all the other parathyroid glands.
Yes, and during that vascular compromise can happen during surgery.
Cushing's it can happen.
Commonest example is TSH remains suppressed after you treat hyperthyroidism, right? After treatment, T3, T4 remains normal, but TSH doesn't come back to normal. That depends on the duration of suppression of an organ.
Okay.
So you have seen that it's very commonly seen that even after treatment of hyperthyroidism, the T3,
yes.
T4 come back to normal, but TSH remains suppressed.
Takes long.
Right?
Yes.
Consider TSH as a follow-up measure for treatment of hyperthyroidism.
Yes.
Similar situation could have happened in this because of prolonged hyperparathyroidism. So much of increased levels of PTH over a long duration of time would have suppressed all the other glands. What was surgery? Only removal of this, or there was any other adenoma anywhere else also?
No, sir. Actually, there's a 90% drop we documented, so we thought it's a normal only, and we followed up. And till now, she never developed any hypercalcemia after that. She's still on the calcium on the 8 range only with the maximum supplements.
Thank you so much.
Yeah, thank you.
Next, we have the Anirban Sardar. Could you please share your screen?
Yes, ma'am, I'm sharing my screen. Good afternoon, everyone. I am Anirban Sardar, working with Dr. Ritu Trivedi at CDRI. Here, I would like to present our recent work entitled Self-Assembled Nano-formulation Ameliorates Altered Bone Metabolism and Body Composition Associated with Overoptimized Rats. Here we tried, we made an approach to synthesize the nano-formulation of pentacyclic triterpenoid, which is a natural source. And we want to check this on the elevated adiposity and bone loss during the overoptimized condition where the ovarian hormone like estrogen are cut down. Initially, we made a collaboration with Dr. Pierre Mr. Lab at the CDRI and synthesized the nano-formulation of naturally occurring pentacyclic triterpenoid. And we had checked that it has a higher bioavailability and the cellular uptake compared to the free drug. And it promotes the osteoblast differentiation at the very low level compared to the free one. And it has also very promoting activity in the mineralized nodule formation as shown in the mineralized nodule formation assay. And the alkaline phosphatase activity was also found elevated at the very lower concentration of formulation treated osteoblast cells. Here we examined the RNA level of genes involved in Wnt beta-catenin pathway, and we found elevation of Wnt 10B and the beta-catenin, which and the down regulating the KK1, which actually indicates that it regulates bone metabolism, rather osteoblast differentiation through the Wnt beta-catenin pathway. In addition to this, we also checked on 33L1 cell, which is considered as a cell line for the adiposity to check the adiposity, and we found that 33L1 differentiation was checked at the day 5, compared to the free one and the control cells, and at the genetic level, at the gene level, SREBP1C, CBP alpha, and FAS, that is the fatty acid synthase genes, was found downregulated in the formulation treated cells. And in the in vivo model, we have taken the overectomized rats, and we found that the femoral metaphyseal regions was found altered in the OVX placebo treated animals, which was found again recovered in the formulation treated animals. And the bone which can be also shown in the BBTV, as well as the trabecular thickness, trabeculus number, and the trabecular separation was found elevated in the placebo treated OVX animal, which was recovered in the formulation treated animal. And in addition to these, we also checked the bone marrow adiposity, which is also another deteriorating factor in the OVX condition, and which is found in the OVX. We found a huge amount of bone marrow adipocytes, which was also checked at the formulation treated animals, as shown in the HG as well as the pedilipin stained cells. And in the next part, we also check the body weight, where OVX animal is the body weight of OVX animal was found in at the very high level, where it was also checked at the formulation treated animal. From our study, we concluded that at least at the preclinical level, our formulation was found excellent, and it can prevent bone marrow adiposity and as well as the bone metabolism. Whereas the formulation need to check further preclinical level, and that's it.
Can you show us the conclusion?
Yes, sir.
What is SD rat?
Yes, sir. Yes, ma'am. It is. We to take SD rats as our model.
What is this nano thing you're talking in this formulation?
Actually, sir, the size of the particles that we synthesized was found below 150 nanometer.
No.
That's why we called it as a nano formulation.
So then there are two types of formulation of pentacyclic terpenoids, right?
Yes, sir.
One is the conventional formulation.
Sorry, sir.
I said there must be two formulations of pentacyclic terpenoid. Whether it is conventional versus nano, have you tried to compare, or you just took only nano formulation?
No, sir. Actually, we try to compare the free form of drug with the nano formulated drug. Actually, what happened with this?
No. Please explain what is this free drug and nano formulation. I have not got that. See, either you have a drug which is conventional, and nano is when it is, when it is broken down into very small particles, nano size particles, so better.
Yes, sir. Yes, sir. Yes, sir.
That is the nano formulation. So
yes,
here,
sir.
You used only nano formulation, or you compared it with the conventional or whatever free item?
We compared. Actually, we compared the free drug as well as the formulated drug.
And what was the size that you brought it down in terms of nanotechnology?
Sir, 120 to 152 nanometer, the diameter.
And what difference did you find in the two when you used the free and when you use nano in terms of its impact on bone loss, preventing bone loss?
Actually, sir, we made an approach to synthesize nano formulation because the drug that we choose.
Listen. Yeah, because it's difficult for us to understand the basic drugs. All right.
Yes, sir.
Yeah, tell me the difference in the action of the free and the nano.
Yes, sir. Yes, sir. Actually, the activated dose was found 500 picogram per ml or 1000 picogram per ml, which is very minimal as compared to the small drug. Whereas betulinic acid, that is what our free drug was, it was found active at the concentration of 10 microgram per kg.
Yeah, 10 microgram per ml, sorry, 10 microgram per ml. Whereas at the same drug in the nano-formulated form, it was found active at the very minimal concentration of 500 or 1000 picogram per ml.
Well, so that I understand that when you have nanotechnology, the absorption is better, so you will need lesser dose. That I
Yes, sir.
But what is that advantage that you have nano over this, except for the dose?
Actually, so butylenic acid has a #1 issue with the bioavailability. It has a very less bioavailability as shown in the cellular uptake assay. It was almost the uptake of the free form at 1 hour was found almost 1.4% or 18.4%. Whereas at the same time frame, the formulation part was found bioaccumulated at almost 35% and 73%. This is the advantages of considering nano formulation.
Okay, just because of bioavailability.
Yes, sir. #1, the bioavailability, and the #2 issue is it is water soluble. The formulation part is absolutely water soluble, but the free drug is absolutely non-soluble, and it is hydrophobic in nature. That's why we have made an approach to synthesize the nano formulation.
Great. Yeah. Thank you so much.
Thank you.
Divya, next is Divya. Yeah.
Divya.
Yes, ma'am, I'm sharing my screen. Hi, I hope my screen is visible.
Yes, it is. Yeah.
Okay. Good evening, everyone. So I'm here to present a poster basically on a compound that we have, not we have, but the chemistry department in CDRI has synthesized and which we have characterized as a BMP2 secretagogue in our previous study that was published in Journal of Medicinal Chemistry. So, so from there we took that compound that is showing a very good osteogenic property and a very efficient fracture healing agent, and from there we have picked up this compound, and considering that GIOP, that is glucocorticoid induced osteoporosis, is the most common form of secondary osteoporosis, and it is an unavoidable drug for treatment of numerous diseases. So considering that into the picture, so we have developed two models, like the in vitro model and the in vivo model. For the in vitro model, the co-treatment of dexamethasone, a well-known glucocorticoid, was given along with our compound, that is 5E. So I think with our compound 5E is that it's a galloyl conjugate of flavonol. So this gallic acid is very hydrophilic, so it cannot be made as a drug. So for that, to increase its hydrophobicity, the moiety of flavonol has been added, and flavonol has been reported as an osteogenic agent in numerous papers previously. So for that, our compound 5E, we did the screening just to choose the dose, and along with dex, and at a very minimal dose of 1 picomolar and 100 picomolar, our compound was efficient in increasing the decreased ALP activity, and it was also efficient in enhancing the mineralizing ability of osteoblast, which was compromised in case of dexamethasone treatment. And also the RENX2 and BMP2 expression in our figure 1 was also decreased due to dexamethasone treatment, which was enhanced by the treatment of our compound 5E. So next thing what we did was that the major signaling pathway, that is Wnt beta-catenin signaling, so that's a major signaling pathway for the osteogenesis. So we checked that if our compound is able to alter this pathway, and is the effect that we are getting is BMP2 dependent or not, because we have already claimed it as a BMP2 secretagogue. So for that, we checked the treatment of the administration of dexamethasone decreased the nuclear translocation of Wnt beta-catenin in figure 2, and our compound was able to somewhat recover the nuclear translocation of beta-catenin. And along with that, we also checked the whole signaling, that is our ligand, that is Wnt3a. Wnt3a was decreased in case of dexamethasone, and it was somehow enhanced and increased in 1 picomolar and 100 picomolar doses. We also checked for GSK3 beta and SOST, which is inhibitor of Wnt beta-catenin pathway. And next, we checked, because in case of dexamethasone, the treatment of dexamethasone alters the NRF2 and antioxidant signaling pathway, which is actually the major cellular defensive mechanism against oxidative stress. So for that, we checked that if dex is able to increase the ROS production, and we found that a significant increase in ROS production was seen in case of dexamethasone administration, and our compound, our BMP2 secretor GOG, was able to efficiently decrease it. And we also checked the translocation of NRF2, which is a very major antioxidant signaling molecule. So we checked in case of dexamethasone, the nuclear translocation of NRF2 was compromised, which was quite somehow reversed in case of our compound. And this ROS production that leads to osteoblast apoptosis, for that we also checked the apoptosis assay, and we found out that our lesser number of apoptotic cells in case of our treatment groups. And we also checked our compound in the in vivo, and we have taken male biopsy mice. So for that, we administered glucocorticoid, that is methylprednisolone, for 28 days. And we found out that the loss in the trabecular was extensive, that we can see in the stats also. And our compound was able to increase the lost trabeculae. So it was actually able to increase the decrease BV by TV, which is the content, the mineral content, basically, that is the bone volume by tissue volume. And the trabecular thickness that was actually compromised in case of the methylprednisolone group, that was also significantly increased, and whereas trabecular separation was also decreased in case of our treatment group. So apart from this, we have also checked in case of in vivo model, we have also checked the loss in vertebrae, and we also found that the lumbar 5 vertebrae, the loss was extensive when we administered methylprednisolone, and our compound was very well able to reverse the loss that was made by methylprednisolone. We also, actually, osteonecrosis is also a major...
Time is over. Can you go to the conclusion?
Yes. So the main conclusion that I want to share is that there is no oral anabolic drug still for fracture healing or for glucocorticoid-induced osteoporosis. So it could be a good candidate in terms of that. Thank you.
So in terms of, translating to, treating human subjects with glucocorticoid-induced osteoporosis.
Yes, ma'am.
How do you see this translating? And did you see flavonoids? I mean, I missed that first part.
Yeah, ma'am, actually, flavanones. So these flavanones are already reported for its osteogenic activity. So actually, the thing with gallic acid is that it is very, very hydrophilic. So we need to make it hydrophobic in just to make a drug, if we want to make gallic acid as a drug. So otherwise it can give false positive result. That is why it comes under the category of paints. I mean, a chemistry person would be able to tell it much better, but yes, it comes under the category of paints. So we have actually attached a molecule of the moiety of flavanone just to make it a little hydrophobic, so that it can be considered as a drug.
Are there any established side effects to this?
Ma'am, we checked the liver sections, the kidney sections. We did not get any side effects. Plus, we have also, while we were doing the in vitro experiments, we also checked for toxicity via MTTSA, and we did not get any type of toxicity.
How do you evaluate this particular case, the significant improvement in terms of particular number, particular weight, the ratios that you take?
So please pardon, I'm not.
Am I audible?
Yes, sir. Now you're audible.
Okay. I said, how did you evaluate the effectiveness of your drug 5E in steroid-induced osteoporosis?
So basically, we are
in terms of trabecular width, trabecular number, or did you take any of the ratios, total volume versus How did you evaluate that effectiveness?
So we had in each group, we had sufficient number of animals, like we take a n is equal to around 10. And for the comparison, we had the control group animals also who were not given glucocorticoid treatment. So we compared our animal groups who were given the compound with the group who were not containing either the glucocorticoid and the drug. So we had control animals, we had the group of animals who were having glucocorticoids, and then we had a 3 different group of animals with different doses like 1 mg, 5 mg, and 10 mg who were given glucocorticoid as well as our compound. So that is how we made the comparison.
So controls have to be only given that particular compound. One is subjects who were on steroids and were given this compound, right?
Yes, yes, sir.
The second subject would have been what? In subject with no steroids.
Yeah, one subject was with no steroids, another was with just steroids, and the third one was the steroids as well as our compound.
So the significant difference was with no steroids or with just steroids?
With the steroids, I would still say that it was not able to match. Hello, am I audible, sir?
Yeah.
So I would still say that it was not able to match. I mean, the condition was not extremely equal to the control groups who were not given any of the two. But yes, it was when compared to the steroid group, they were highly significant.
Thank you so much. Yeah.
Thank you, ma'am.
Shivani Sharma. Share your screen. Shivani Sharma.
Am I audible, ma'am?
Yeah, yes, Shivani.
My screen is visible or not?
Not yet.
Now?
Yes. Yes, it is.
Good evening, everyone. I'm Shivani Sharma. I'm doing my PhD under the supervision of Dr. Naivedya Chattopadhyay in CDRI. Topic of my presentation is Dasmine, a citrus fruit derived bioflavonoid, protect rats from chronic kidney disease induced loss of bone mass and strength without deteriorating the renal function. Sorry. So, as CKD, that is a chronic kidney disease, is a progressive condition which affects around 5 to 10% population globally, as it is caused by abnormality in a mineral metabolic process, which lead to CKD MBD condition, that is mineral bone disorder, which further increases the risk of fracture. So according to KDGIO, that is Kidney Disease Improving Global Outcome Guideline, it recommends treating osteoporosis, that is a condition with low BMD, with the first line anti-resorptive drug, that is bisphosphonate, to reduce the risk of fracture. However, it is recommended for the patient with early stage of CKD. As CKD stage advances, BP, that is bisphosphonate, have the concern of worsening the kidney function. Thus, there is an urgent need for safe and effective treatment of osteoporosis in CKD patients. For this reason, we checked the effect of Dasmine in the CKD-induced bone loss. Here we established a CKD model by surgery, that is by performing 5/6 nephrectomy in SG rat. And the establishment of this CKD model is a two-step procedure in which first the 2 poles of left kidney were removed, which leave 2/3 of tissue behind, and after giving 7 days of rest, the entire right kidney then removed. And on the day 15, we categorize animal in sham operated group, that is animals with intact kidney, then CKD group, and then Dasmine treated CKD group. Here Dasmine is given, a human equivalent dose of Dasmine is given to CKD rats. As CKD condition get advances, it leads to accumulation of uramic toxins such as burn and creatinine, which we checked by doing ELISA, and we found that in CKD, burn and creatinine were elevated, and diastmin does not further worse this level of burn and creatinine. As burn and creatinine levels were increased, it further elevated the PTH and FGF23 level, and this diastmin is capable to reduce both this PTH and FGF23 level. Further, we assess. Then next we assess the diastmin effect on bone mass and microarchitecture in CKD rat by doing microCT technique. As in CKD rats, bone mass was reduced and deteriorated microarchitecture of trabecular bone was found, and diastmin is capable to maintain both of this, that bone mass and bone microarchitecture to sham level. Then we checked bone surface referent parameters. Yes, ma'am.
Shivani, you have to conclude because the time is up.
Okay, yes. The active metabolite of diastmin is also having the same osteoanabolic effect, as well as it is capable to protect against CKD-induced osteopenic condition. So, conclusion of my study is that diastmin and its metabolic surrogate, that is diastmin, protects CKD-induced osteopenia and could be a potential drug with anti-resorptive, anti-osteoporotic effect in CKD patient.
Does diastmin have anti-resorptive action in normal patients also?
Sir, please repeat your question.
Does diastmin have the same effect in normal patients also? It is only...
मैंने तुम्हारा नहीं सुना साले मैंने दिव्या के तुम्हारा खत्म हो रहा था
Sir, your voice is not audible to me.
शिवानी का चल रहा है
Between voices.
दिव्या से क्या क्वेश्चन पूछ रहा है कि तुमने का एनिमल एक्सपेरिमेंट कैसे मतलब तुमने कैसे
अरे इन लोगों के सामने नहीं
Hello. Sir, please continue your question.
I'm saying that does diastmin have the similar kind of effect on normal osteopenic or osteoporotic?
Yes, sir. Yes, sir. It is osteoanabolic in its activity in growing rat, as well as in fracture model, as well as in OVX rats.
Is it as effective as in CKD patient?
Yes, yes, sir. It is as effective as in CKD patient.
How do you say that?
Sir, as in our study, not in CKD patient, it is still
my question is diastmin, diosmin?
Yeah.
Metabolic surrogate, whatever you use.
Yeah, diastmin is
action is similar both in normal subjects, osteoporotic subjects, as well as osteoporosis in CKD patients, right?
Yes.
Sorry, sir, the time.
Yes, it is because it is capable to restore bone microarchitectural parameter in both femur as well as in tibia.
Thank you, Shivani.
I request all participants to stick to the time. 3 minutes for summarizing the poster. Need not present the entire poster, can summarize the poster, and just 2 minutes for discussion. So next we have Dr. Fauzi Nabi. Sir, are you ready, sir? Can you please share your screen?
Dr. Nabi, are you ready to share your poster?
The other participants have to unshare.
Good evening, judges and delegates. I thank the organizing committee for giving me the opportunity to present my paper. This is a case report which is on this is acute recurrent pancreatitis secondary to primary She had a recurrent pancreatitis secondary to primary hyperparathyroidism. As we know, acute pancreatitis is usually caused by gallstones and chronic alcohol intake. But as we know, pancreatitis can be also caused by PHPT as well. And estimated prevalence has been reported from literature of around 1.5 to 7%. And the risk of PHPT causing pancreatitis is around 10 to 30 folds. And in this case, we reported a 30-year-old female who was previously had 2 episodes of pancreatitis, and the calcium reports were high normal range. And nothing was done. She was evaluated for other causes of pancreatitis, autoimmune pancreatitis profile. It was negative. This was the 3rd episode of pancreatitis where the calcium report was 10.8, albumin, serum albumin was 3.48, corrected calcium was 11.2, our PTH was 180, 24 urinary calcium was 340. So UAG abdomen did not read, there was no history of nephrolithasis. DEXA scan was done, there was no bone involvement. Then thinking of PHPT, PTH dependent hypercalcemia, systemic scan was done, which showed left inferior parathyroid adenoma. She underwent a successful parathyroidectomy with normalization of serum calcium post-surgery. And there further follow-up at 6 months, there was no episode of pancreatitis. So she had 3 episodes of pancreatitis in past 2 years. And she had also mild glucose intolerance, which was managed with metformin. This is a CT showing a necrotizing pancreatitis or involving the body of the pancreas. This is a systematic scan, delayed washout scan showing the uptake at the left inferior parathyroid adenoma. So in PHPT, due to parathyroid adenoma is a rare cause of acute pancreatitis and should be considered when the etiology of pancreatitis is unclear, and patient may present with recurrent episodes of acute pancreatitis without any clinical presentation of PHPT, without bone involvement or any renal involvement. So the presence of high normal to elevated level of serum calcium should raise a suspicion of PHPT in the presence of pancreatitis, because usually normally in presence of pancreatitis, serum calcium usually remains normal or it may be low. So presence of high normal or elevated calcium should raise a suspicion of PHPT in these patients.
Yeah. Conclusion. Yeah. So he's concluded. Quick question. This association
is that high normal serum calcium in a patient of recurrent pancreatitis, which should evaluate for PHPT without any, even they may not have a manifestation of renal or bone involvement in this patient. So this patient did not have a manifestation of bone or renal involvement. She had only a presentation as pancreatitis as a manifestation of PHPT.
Dr. Maithili, do you want to ask anything?
Anything special in this case?
Special was recurrent pancreatitis. Initially, she was missed as PHPT and she did not have any bone or renal involvement.
Okay, Usha, we'll move on.
Yeah, thank you.
Thank you.
All the calcium went to pancreas.
Any elevated calcium will work up.
Yeah, but we normally maintain high normal should be suspected, no?
Dr. Soham Mukherjee.
Yes, ma'am. I'm just sharing my screen. Is my screen visible?
Yes.
Yes. So, good evening, everyone. I'm Dr. Soham Mukherjee, Assistant Professor in Endocrinology Department, PGI Chandigarh. I'm presenting a very interesting case of digit disease of bone who initially presented with gradually progressive quadriparesis. So, my patient is a 49-year-old gentleman who presented with gradually progressive muscle weakness involving all the 4 limbs for last 4 years, as well as low backache for last 2 years. there was a reduction in muscle power involving muscles of all the four limbs, particularly the proximal muscles, and some distal muscles were also involved. The calcium profile were essentially normal except for the alkaline phosphatase, which was sky high, that is 878 international unit per liter. And the bone turnover marker were also raised. EMG showing mixed myogenic and neurogenic pattern. And on MRI spine, we did not find any spinal cord involvement. However, there was diffuse hyperintensity of T1 and L2 vertebral body. On X-ray, everyone can appreciate that on the L2 vertebra there is sclerosis. Along with the sclerosis in the upper end plate of L3 vertebra with some lytic area. So we proceed for nuclear imaging. Bone scan suggestive of increased stressor uptake at various skeletal site, and FDG PET CT also concordant with that finding with multifocal increased stressor uptake in various parts of skeleton. Here I'm representing an axial image where you can appreciate that L2 vertebra is visible, where there is increased pressure availability in FDG PET CT. Actually, we administered the patient with zoledronic acid. The reason I will discuss later. And after zoledronic, 3 months after zoledronic, you can appreciate there is a marked reduction of FDG ability in the same site. We also went for bone biopsy and muscle biopsy. In the bone biopsy, there was area showing lamellar bone formation with osteoblastic activity as marked in the black arrow, along with increased osteoclastic activity. And in muscle biopsy, there was neurogenic atrophy along with inclusion with rimmed vacuole, which also can be appreciated in the gomoid strain. So, inclusion body myositis with Paget's disease, the diagnosis was made, and the combination is actually rare. This is a part of spectrum of disease known as inclusion body myopathy associated with Paget's disease of bone and or frontotemporal dementia, shortly known as IBM-PFD. And the diagnosis was confirmed in clinical exome sequencing, which was suggestive of heterozygous mutation in VCP gene. VCP is velocin containing protein. It is important for proteasomal degradation and mitochondrial autophagy. Yes, I just 10 seconds. We administered zoledronic acid in the patient, and the patient responded biochemically, clinically, along with the nuclear scan already I have discussed. Physiotherapy was initiated for inclusion body myopathy. So, a high index of suspicion for IBM-PFD should be kept in mind in any patient of Paget's disease who presented with muscle weakness. This is a very rare case. Only approximately 15 cases of this entity has been reported till now. Thank you.
Have the other studies also used zoledronic acid, or you thought this was your first time that you thought of?
Actually, sir, it is a case of Paget's disease. So we treated as far as the standard protocol, as we have others done in Paget's disease. It is a component of the complex syndrome. That is the rare in this case. Otherwise, we have treated the patient with Paget's disease, and after zoledronate, 6 months after zoledronate, the alkaline phosphatase was only 8, and the backache and bone pains reduced markedly in this patient.
So what was the impact of physiotherapy?
Pardon?
What was the impact of physiotherapy on the muscle?
Okay, sir. So basically, for inclusion body myopathy, for the inclusion body myopathy part, there was no available treatment except for the physiotherapy, and we consulted the neurologist, and they advised for the same. No, it has nothing to do with the Paget's disease part.
Did you see any improvement? I'm asking you.
Sir, this is only static. There is no improvement, but there is no degradation either.
Okay, thank you. Thank you. We'll move on to the last one.
Thank you. Okay.
Kriti Sharma.
Pardon?
Unshare your slide so Kriti can start.
Okay. Yeah, I am facing difficulty. I just switch off my laptop.
Work. Kriti Sharma, please share your screen.
Am I audible? Ma'am, my slide is visible to you.
Your voice is not clear.
Please put in slideshow.
Is it clear?
Your screen has disappeared. Shall we see? So the next one? If she's having some problems.
Sure.
Okay, you can start presenting.
Shall I start the presentation?
Sure, please.
The time starts.
Okay, start the presentation. Okay, thank you, ma'am. So I'm Kriti Sharma, working as DST SRF under the supervision of Dr. Divya ma'am in CDRA. The topic for my poster presentation is the ethanolic extract from C8 promotes fracture healing by reducing reactive oxygen species level. So fracture healing is a complex process of bone regeneration and repairment. Every year, around 8.9 million osteoporotic fractures occur worldwide. Besides the available pharmacological medication that are available for fracture healing, the natural phenolic compounds and also have the property of bone healing can also be used as an alternative strategy for the fracture healing. So C8, which is the plant, which is a code of my plant, is a perennial flowering plant, belongs to the family Aponeaceae and found in India. Traditionally, it has been used for its anti-inflammatory and antibacterial properties. So the objective of my study was to investigate the effect of this ethanolic fraction of a C8 plant on the fracture properties. So the methodology which I adopted for the in vivo study, we took Swiss mice, did the drill hole injury in the female mid-diaphysis, and the mice were autopsied at 2 time points, 7 and 14 days. The in vivo groups were controlled, PTH, which was used and positive control, and 1 mg per kg body weight, 5 mg and 10 mg doses of C8 plant was used, and following So coming on to the result, first of all, we checked the its in vitro efficacy on the osteoblast differentiation using ALP and MTT assay was used to check the toxicity level of this ethanolic extract of plant. Then the amazing results of the ALP and MTT assay prompt us to directly went ahead with the in vivo study, where you can see in 7 days and 14-day time point with respect to the control group, all 3 doses of C8 plant, that is 1, 5 and 10 mg, has enhanced the fracture healing process by increasing the ratio of bone versus tissue volume, connective density and trabecular thickness. These results were also excellent in binding images. Then further, the effect of C8 ethanolic extract was also been determined on the mineralization, where you can see all the doses of C8 has effectively enhanced the mineralization. Then the remarkable feature of this plant extract is it decreases, and also it reduces the expression of pro-inflammatory genes. So in conclusion, I would like to say that this plant extract demonstrates it has the potential bone regeneration power, and also it can be used for the delayed union and non-union fractures by reducing the inflammation and also by reducing the reactive oxygen species level. Thank you, ma'am.
So if the effect is coming only on the cortical bone.
Hello.
Hello. Can you hear me?
Yes, sir. Sir, your voice is not coming properly. Yes, sir. Yes, sir. Yes, sir. Now I can hear you.
Okay. It's again gone.
So what was your question, sir?
I said, does this have effect only on the cortical bone or also on the medullary bone?
Sir, actually, we have done this. So here we have done the mid-diaphysis. We have chosen the mid-diaphysis region of the cortical bone. So the simultaneously studies has been also going for this osteoprotective role. Where we have done the fracture or the drill hole in the epiphysis region of the bone. So this study basically tells about the cortical bone defect or bone properties of this particular tract. Is that answer your question, sir?
Whether it has effect on medullary, what you have done is an issue. See, there are 3-4 flavonoids already showing the effect on the bone. I've been hearing this for the past so many years from CDRI. Different flavonoids, different drugs having anti-osteoporotic effect.
Yes, sir.
But nothing seems to be coming out even after years for human trials. So my question was that you've shown the impact on the cortical bone, not on the medullary bone. So in the vertebrae, when you have osteoporosis, we would like to see the impact primarily on the vertebra.
Yes, sir.
Then you can't
Sir,
use
actually,
this.
am I audible to you? Okay, sir. Sir, here we actually aim for the fracture healing property of this particular tract. Here we are not focusing on the osteoporosis or the bone formation in anabolic mode, in the therapeutic mode. We are focusing on the fracture healing property of this particular tract. And the remarkable feature of this extract that being an extract, the doses was being used at 1 mg, 5 mg, and 10 mg. So after the compound isolation process, the active moiety or the active compound which we will use for the further investigation would be very low when it will be reciprocated in the human data. So that is it. I'm not able to hear you, ma'am.
Please unshare your screen. Now, Sonu Kanka. Sonu Kanka, please share your screen.
Sonu, can you hear us?
Sonu?
Okay, then we can go to Dr. Ms. Babu.
Oh, Sonu is doing.
Oh, you're sure.
No, busy.
Yeah, go ahead. Sonu's thing is coming up. Sonu, can you hear us? No.
Share the screen, but she's not responding.
Sonu, can you hear us?
She is. Please unmute her.
Sonu Kanka. Sonu Kanka.
Share the screen, but she's not responding, so we are not able to share
Her screen, I know.
Hello? Hello?
Yes, we can hear you. Can you go ahead?
Okay. Sorry, ma'am, for inconvenience.
Good evening, everyone. I am Sonu Khanka from CDRI from Dr. Divya Singh's lab, and I am presenting my work entitled as Butia monosperma total extract avert bone loss and elevate bone mineral density without causing uterine hypertrophy in overectomized rats. And the background is that there are many therapeutic agents for the treatment of osteoporosis which are associated with different side effects. Therefore, there is an unmet need for alternative therapies from natural sources such as phytoestrogen. The Butia total extract isolated from the Butia monosperma rich in different methoxy isoflavones, and one previous study showed its osteoprotective effect in rat model of the osteopenia. However, the preventive mode of action of the Butia total extract never been explored. Based on this background knowledge, the aim of the study is to determine if Butia total extract can prevent the onset of disease in prophylactic model of the osteoporosis. For this study, the adult SD rat were overectomized, and treatment of Butia total extract with 3 different doses were started from the next day of overectomy and continued for 12 weeks. After autopsy, the bone and serum sample were collected for further experiments. From these experiments, we got the results. The first panel show that in overectomized there is increase in body weight, and there is no change, much more change in the body weight of BT treated group, and the uterine weight decreased in the OVX group, which were, and Butia total extract didn't show any change in the uterine weight, which indicates that no uterine hypertrophy associated with the Butia total extract. The second panel and third panel shows that the microcity data that Butia total extract increases or maintain the different trabecular and cortical parameters, and also increases the BMD and bone mineral content of both trabecular and cortical bone. And bone strength parameter, power, energy, and stiffness also increased in Butia treated groups. The bone formation and resorption markers, the ELISA study revealed that the bone formation marker P1NP is increased, and the bone resorption marker CTX was decreased in the Butia treated groups. And the HE staining of human trabecular bone showed that the Butia total extract at 250 mg maintained the trabecular connectivity, which was degraded in the OVX group. The double calcium labeling, we observed double calcium labeling and found that the mineral apposition rate and bone formation rate and mineralizing surface upon bone surface was increased in Butia treated group in comparison to the OVX group, and the confocal imaging of the calcium labeling showed these results, that there is a clear double lining in the Butia treated group at 250 mg. And the osteogenic gene expression for NEX2 and type 1 call also increased in Butia treated groups at 250 mg dose. And the conclusion of the study is that the best protective effect was observed at 250 mg dose of the Butia total extract. And this study claimed the prophylactic mode of action of Butia total extract in overectomy induced bone loss by maintaining bone mass.
Sonu, your time is up.
Okay, sir. And overall, the study advocate the use of Butia total extract for management of postmenopausal osteoporosis by delaying the onset of bone loss because of the estrogen deficiency. Thank you. Thank you, sir. Please, question, please.
Maitri ma'am, you have any questions, ma'am?
No, we'll move on.
Okay, coming to the last presenter, we have K. Babu. Sonu, please unshare your screen.
Good evening all. Today I'll be presenting a work entitled Bone Health in Mandaki Females, cross-sectional study. So microenvironment plays an important role in the functioning of any cell, and so does in the skeletal. A small change in the O2 levels disturbs the homeostasis between the bone formation and bone resorption, which are continuous and simultaneous process and called bone rebonding. The hypobaric hypoxia is a major challenge at high altitude, and short-term and short-term studies on male volunteers have shown that bone deteriorates at high and extreme altitude after a stay of 14 and 16 weeks respectively. High altitude natives have acclimatized to high altitude environment and hence may represent long-term effects of high altitude on bone health. Studies on high altitude natives have found that they have fracture-prone metacarpals and have enlarged medullary cavity that may be for increased erythropoiesis, increased red blood generation that is required at high altitude. Major studies at high altitude have been reported on male volunteers, and they okay. So to summarize, we found that there is an increased incidence of osteopenia among the Ladakhi females at both sites that were analyzed, that is radius and calculus. And though it was not significant, but slightly low BMD was found for Ladakhi females. Increased serum calcium, significant increase in the serum calcium was found despite the fact that IPTH and vitamin 25 vitamin D was low. This may be because of increased bone resorption that may be happening at high altitude. Low CT, in spite of high serum calcium, was surprising and need further evaluation. There was an increase in bone BAP, bone-specific alkaline phosphatase, which is a bone formation marker, and which also requires more investigation, because just because of one marker, we cannot say that bone formation is happening, increasing at high altitude. Other markers of bone formation and resorption need to be analyzed to say anything about the bone health of Ladakhi female population. That is the summary of my poster.
What was the intake of calcium in the
Sir, it was comparatively low as compared to the sea level. This thing. We had a dietary call from them, and it was comparatively low.
No idea how much.
I have no calculation about.
And the low bone density that you're showing for
yes, sir.
is shown in any case all Indians all over. The bone density is low
for bone,
for only distal radius and all.
Sir, we
have seen that all normal as compared to Caucasian. Even the healthiest of the people, like Javans also, this bone density of the hip and at the lumbar spine was even higher than that. But the bone density at radius was significantly low, which has been seen throughout in all our studies.
So, sir, in this case,
that
we are
doesn't
not.
Give me any significance about your findings. That's why I'm trying.
No, sir, we didn't find any significant difference between the both the groups. First of all, we were only comparing two groups, so it was not with any other group. Like we are doing a Caucasian versus, it was a control versus sample group. So sea level volunteers were there and the Ladakhi females.
Thank you. Thank you.
It was ultrasound or the other one?
So this is a
peripheral or ultrasound?
It's not ultrasound. It's not ultrasound.
Which make is it? I haven't seen any peripheral DEXA except with me when it was done. Now do you have peripheral DEXA? Or it was ultrasound? Methodology में लिखा होगा?
No sir, methodology में I just mentioned.
Are you the principal in?
No. I am just a student.
Presenting somebody's case.
No, I'm not presenting anybody's case. This is I started with my PhD, and this is just this thing.
So when you do not know, when you start your PhD, the first thing you should know is what equipments are you using yourself? What is the significance of their use?
I get it. I'm just not remembering.
Anyway,
so,
okay.
Thank you so much. We have concluded the second session. Thank you so much, Professors Usha Sriram ma'am, Marwa sir, and Maitri ma'am. We will now go on to the third.
Thank you, bye.
What you can place from my side.
Third session, the judges are Dr. Alok Sachin sir. Okay.
Yeah, good evening, I'm there.
The first presenter is Praveen Kumar. Are you there? Praveen Kumar, please. Yeah, please. Roshan Naziruddin, please start sharing your screen.
Yes, ma'am.
Please finish your presentation in 3 minutes. We are running short of time.
Is the screen visible now, ma'am?
Yeah, it's visible.
Okay. Respected judges and dear friends, I'll be presenting the poster Polyostotic Fibrous Dysplasia, a great masquerader of McCune-Albright syndrome. McCune-Albright syndrome is a rare disorder with characterized by the triad of macutes, fibrous dysplasia, and endocrine dysfunction, typically precocious puberty. The presence of any two of these three criteria is enough to make a clinical diagnosis of McCune-Albright syndrome. Polyostotic fibrous dysplasia may be asymptomatic or may present with facial asymmetry, bony pain or deformities, pathological fractures, visual or hearing impairment, or basilar invagination, depending upon the site and severity of the lesions. Typically, these lesions appear in childhood and adolescence and are rare in adults. Here we report the case of a 19-year-old female who had presented with secondary amenorrhea, and she had a past history of being treated for precocious puberty. On evaluation for secondary amenorrhea, she was incidentally detected to have lesions suggestive of fibrous dysplasia on MRI brain. On examination, there were multiple cuff-facial macutes, no bony tenderness or deformity, pathological fractures, facial asymmetry, visual or hearing impairment, and no features of thyrotoxicosis or acromegaly were present there. Routine investigations were normal. Serum calcium, phosphorus, alkaline phosphatase, and parathyroid levels were also normal. and on hormonal evaluation, there was elevated estradiol levels with pubertal range LH and suppressed FSH levels. Serum cortisol was adequately suppressed following an overnight dexamethasone suppression test, and growth hormone levels were also adequately suppressed following a 75-gram oral glucose challenge test. On imaging, the CT and the MRI showed the features of fibrous dysplasia with ground glass appearance involving multiple cranial bones, including the bilateral frontal bone, the left maxillary and mandibular bones, and the sphenoid and ethmoid middle bones, along with the narrowing of the bilateral optic foramina. Bone scan, a technetium 99 bone scan was done, which confirmed the diagnosis of polyostotic fibrous dysplasia with the increased uptake in multiple sites, including the craniofacial bones, as well as the shaft of the left femur, bilateral tibia, and the scapula. So a diagnosis of McCune-Albright syndrome was made, and on follow-up, the patient developed headache and the bone scan admission like. Hello.
Roshan, please conclude in 20 seconds.
Yeah. Okay. On follow-up, patient developed headache and hip pain and was treated with solitonic acids and NSAIDs. Medroxypyrazole followed by oral contraceptives were given, following which menstrual cycles were resumed.
Time is over.
Okay. Yeah, so that was a nice presentation. What was the cause of secondary amenorrhea in this case?
There were multiple cysts, ovarian cysts on ultrasound in the ovaries, and it is felt that probably due to the cyst, the cycle.
Sorry?
There were multiple ovarian cysts on ultrasound, and so probably because of the estradiol secretion from the ovarian cysts, the gonadotropin levels were altered and leading to suppression of the normal cycles.
Okay. So, and this bone scan which you have shown, is this bone scan means at 19 years of age, at a growing skeleton, there will be a lot of increased uptake. So this asymmetry is there only in a few places. Skull and femur, yes, in femur one place, but otherwise bone scan looks something like that of a growing person. Okay. The nuclear medicine people felt that this is really polyostotic fibrous dysplasia.
Yes, sir. We had discussed with them. They've told that it is suggestive of polyostotic fibrous dysplasia early, and there was increased uptake, especially in the craniofacial region.
Yeah, that's right. In skull, there is increased uptake, and there is slightly increased uptake in the femur also. That is on the left side, I think.
Yes, sir. And on discussion with the as the patient grows, the activity will decrease, which could be why there is not that much intense activity.
Right. Okay. Thank you. We can go to the next case.
Thank you, sir.
No, but if I have question, then
Please, sir, please.
Actually, past history of precocious puberty is there, and you are getting evidence of polyostotic fibrous dysplasia. Then your title itself, masquerader of McCune-Albright syndrome, is doesn't fit with, because it is classical. It looks like McCune-Albright syndrome. Only thing you have to search for cafe-led spots. That's all.
Yes, sir. Actually, initially
Thank you.
It was not available. We only elicited on further evaluation. That's why we put it. Thank you, sir.
Dr. Roshan, am I audible, please?
Yeah.
Am I audible?
Yes, sir. 1 minute.
Dr. Roshan, you have one more, please.
Yeah, one more case is there. 1 minute, sir. Yes, sir. 1 minute, please. I'll share the next.
Okay, we'll go to the next presenter, Dr. Praveen. Excuse me. Okay. That starts now.
Good evening, respected judges and my dear friends. I am Dr. Praveen from Care Hospital, Hyderabad. And my title of presentation is Denosumab in the management of refractory hypercalcemia due to vitamin D toxicity. Vitamin D is a hormone with increased projection of multiple health benefits. Vitamin D toxicity is usually iatrogenic but can also be due to self-medication. The spectrum of vitamin D toxicity varies with the severity and duration of hypercalcemia, can often be debilitating. The management will be challenging with refractory hypercalcemia. I present a case report of 29-year-old young male who presented with persistent polyuria, polydipsia, and significant weight loss with a decreased appetite of 15 kilograms over 2 years. With history, we had a vitamin D deficiency in the past for which he was advised 6 lakh intramuscular injection status, but he took 30 doses over 22 months. At presenting, investigation showed calcium of 11 milligrams per deciliter, PTH was normal, vitamin D was more than 150 nanograms per deciliter with normal creatinine. Previous calcium reports showed ranging between 12 to 13.5 milligrams per deciliter. The provisional diagnosis was PTH independent hypercalcemia secondary to vitamin D toxicity was considered and further evaluation was not done. In the past history, with the therapy he had received, we could see that he had taken 2 doses of bisphosphonates. He was also being treated with IV fluids in the past, like SOS basis, plus hydrocortisone was used. We directly started him on denosumab, 60 milligrams subcutaneous shot, along with increased salt intake, plenty of oral fluids, with furosemide, 40 milligrams once daily. We added rifampicin, 450 milligrams once daily at the point of presentation. Within 3 days of initiation of the denosumab, like he had an episode of hypoglycemia with symptoms and documented to be 7 milligrams per deciliter. So the next dose of denosumab was skipped, and we just monitored his calcium levels, which were consistently normal till the month of for the next 70 days, and it was noticed to be 11.6 on 23rd of March, wherein the second dose of denosumab was repeated after about 70 days. And later on, like serial monitoring of calcium has been done in this patient, and he has shown it's been in normal calcemic range. And in the month of May 21st, like he himself discontinued rifampicin, but when we come for the next follow-up, we could see that. And after that, presently is not on any medications. Coming to the discussion part, most cases of vitamin D toxicity are iatrogenic. Vitamin D is stored in the fat, and hypercalcemia in these situations is severe and prolonged. Denosumab, a fully human monoclonal antibody that specifically binds RANKL, reduces the function for formation and function and survival of the osteoblast, which results in decreased bone resorption and prevents hypercalcemia. Various enzyme inducers like ketoconazole, barbiturates, rifampicin, can induce metabolism of vitamin D. Rifampicin will induce cytochrome 3A4, increase the catabolism of both 25-hydroxy and 120-hydroxy to inactive form of vitamin D. To conclude, this case report highlights the risk of self-medication, and in situations of refractory hypercalcemia, use of denosumab at the appropriate time can reduce the ordeal of this debilitating condition. It is safe even in severe renal dysfunction, and rifampicin as an enzyme inducer can be complementary to the treatment of denosumab. Thank you.
Whether heavy saline load with forced diuretics was attempted or not?
So in the past it was attempted, sir. In our admission it was not tested.
And you said he received 30 injections of 6 lakhs unit vitamin D in 22 months.
No, sir. Over 2 months.
Over 2 months.
Yes, sir.
So previously, when he was given zoledronic acid, did it result in any response at all, or did it not result?
Mute. You just
Previously, when zoledronic acid was given, did it give any response, or was there no response at all with zoledronic acid? Hello? Hello? Hello?
Your voice is not audible, sir.
Yeah.
Message him.
Okay, right. I will do it now.
No speak.
Sir, please increase the volume of the device.
Yeah, I will try to do that. So,
sir, are you plugged in with your headphones?
Is it working now?
Please remove and talk now, please.
Okay, right. So is it better? Can you hear me? Is it better? Can you hear me now?
Yes, sir.
Yes, sir.
Okay, so previously when this guy was treated with zoledronic acid, did it result in some improvement?
No, here also it is.
Hello, can you hear me?
Yes.
Now it is all right.
So previously when this person was treated with zoledronic acid, did it give any improvement, or was there no improvement at all?
Sir, no improvement with zoledronic acid in this patient, sir. He continued to have hypercalcemia, sir.
Hypercalcemia did not resolve at all.
It did not resolve, sir. Transiently, there were readings like which came to the normal range, but again, it continued to be in the higher range, sir.
How high was the serum vitamin D at the beginning?
Sir, actually, vitamin D, this person was obsessed and kept on repeating vitamin D. Most of the time, it was more than 150 nanograms per deciliter. One or the other readings were about 42 and 60 nanograms per deciliter. In between, sir, again, it would go high above more than 150.
Right. Okay. Thank you.
Thank you, sir.
The next presentation,
Joel Franklin.
Joel Franklin. Yes.
Good evening. I'm Dr. Joel Franklin from Amrita Institute of Medical Sciences. I'm going to present about Fanconi syndromes due to monoclonal gammopathy, delayed diagnosis, and atypical features. Introduction: Fanconi syndrome refers to dysfunction of proximal renal tubule characterized by glycosuria, amino aciduria, uricosiria, phosphaturia, and proximal renal tubular acidosis. Etiology of
Joel?
Yeah.
Dr.
Yes?
Joel, you can start presenting.
Oh. Can you hear me?
Sir, we can't hear you. If you are using headphones, please unplug the headphones and talk, sir.
No, I'm not. I'm not using. Hello, can you hear me?
Yeah, I can hear.
He has shared the screen. Dr. Joel, we are unable to hear you.
Actually, Alok sir can hear me.
Problem is solved.
Yeah,
Okay, please unshare the screen. Till the problem is solved, we'll go to the next participant. Dr. Rohit Barnabas. Dr. Rohit Barnabas, can you please share your screen?
Yes.
Dr. Rohit?
I'm trying to share the screen. Just one
Can
minute.
you hear me?
I can hear you. Can you hear me?
Dr. Rohit?
Can I do next? Yes. I will just sort it out. Can I do next?
Okay.
I'll just sort it.
Dr. Akanksha Gautam, please share your screen.
Okay. I'll make it.
7.
Am I audible?
Yes. Please share your screen and start presenting.
Okay. Good evening, judges and colleagues. I am Dr. Akanksha. I am from BJ Chandigarh.
Click to make changes
The
anta ide.
topic,
Allow ಮಾಡ್ತಾ ಇಲ್ಲ.
the topic of my poster, it is impact of preoperative zoledronic acid on bone health indices in patients with primary hyperparathyroidism after curative parathyroidectomy. This was a randomized controlled trial. So in the background, we know that the role of preoperative bisphosphonates in the prevention of post-parathyroidectomy hungry bone syndrome, it's not clear. We have case reports of even severe hypocalcemia and severe hypophosphatemia after use of zoledronic acid. And on the other hand, we also have case reports of the use of bisphosphonate preventing the occurrence of hungry bone syndrome. Also, its effect on the bone accrual that assists post-parathyroidectomy, it is not clear.
Dr. Akanksha,
So
your screen is not visible. Your screen is not visible.
You share your screen.
Sir, okay, sir, I will do it again, sir.
Are you able to screen? I'm sorry, share.
She's doing.
Yeah. Is it visible now?
Yes.
Yes, yes. Visible.
Please go ahead.
Yes.
Yes. Okay. So I'll continue. So the primary objective was the study was to see the effect of zoledronic acid on development of hungry bone syndrome and also in the change in bone mineral density that is expected to occur at 1 year follow-up. And the secondary objectives were to see the effect on the bone turnover markers as well as trabecular bone score. So this was a prospective single-center, single-blind randomized placebo-controlled trial which was conducted between 2019 to 2021. We recruited adult patients aged more than 18 years with PHPT along with a calcium level of more than 11 milligram per deciliter. We excluded the patients with a creatinine clearance of less than 30, pregnancy, lactation, and who had received any other anti-resorptive therapy, as well as patients with any chronic disease which will affect the bone health. And also, so we randomly divided the subjects into two groups. One received zoledronic acid and the other placebo. And we made sure that the patient was vitamin D sufficient prior to administration of the intervention. And the patients were then followed up first in the post-op 1 week and also at 3 time points within 1 year, between 6 weeks to 3 months, between 6 months to 9 months, and between 12 months to 15 months. And the DEXA scan and TBS, they were done at baseline and 1 year post-surgery. So in the results, we were able to recruit 48 patients and which made it 24 patients in each of the two groups. The mean age was 46.05, while the female is to male distribution was 3.36 is to 1. So as far as the primary objective was concerned, the hungry bone syndrome, total 12 patients had a hungry bone syndrome and 6 patients were there in the placebo group and 6 in the zoledronic acid. There was no difference in the occurrence of hungry bone syndrome in both the two groups. The odds ratio was not significant, and we also adjusted for baseline CTX, lumbar spine BMD, NOF, neck of femur BMD, and vitamin D. Basically, the baseline we adjusted for the baseline severity as well as vitamin D levels, and we found that even after adjustment, there was no difference, and the odds ratio was still not significant. And even on intention to treat analysis, no significant difference was found between the two groups. About the BMD change at 1 year, the change in BMD was more in the zoledronic acid group as compared to placebo at lumbar spine BMD as well as at neck of femur BMD. The change in the distal
time is up. Time is up. Please conclude.
Okay, so basically a higher BMD gain was seen in the zoledronic acid group, and also about the bone turnover markers, the CTX was more suppressed in the zoledronic acid group, while the bone formation markers, they were not significant. So basically, we conclude by saying that zoledronic acid, it does not prevent hungry bone syndrome, but it can safely be given without a risk of decreased bone accrual, and it's actually there is increased bone accrual with zoledronic acid. Thank you.
Yeah, so that was good. Can you hear me?
Yes, sir.
Right. So what was the total number of cases in both the groups, zoledronic acid versus placebo?
So 24 in each group, sir.
24 and 24 age group. And you found that the BMD approval was better in the patients on zoledronic acid.
Yes, sir. At the lumbar spine BMD, there was a significant difference. Yes, sir.
Right. Okay. So you recommend that zoledronic acid should be given to everybody who is who has osteoporosis at the time of presentation?
Sir, as per this study, yes, sir. It can be safely. It won't be able to prevent the hungry bone syndrome, but it will only help in the gain in BMD, sir.
Right. So what do you think will be the mechanism? Why should it cause that?
Sir, maybe it is able to suppress the osteoclast resorption more effectively. Zoledronic acid.
Okay, thank you, Dr. Modi. Sir,
whether vitamin D was corrected in both the group before surgery?
Yes, sir.
Vitamin D level was normal?
Yes,
before
sir.
surgery?
It was comparable in both the groups. Yes,
Was
it was
checked?
normal. Yes, it was checked, and the patients who were found to be insufficient, we gave them daily vitamin D for 7 days. Hello, sir. Yes, sir. Sir, I'm able to hear you, sir.
Hello?
Hello.
Am I audible?
Yes, sir. You are audible, sir.
Are we audible?
Hello.
Yes. Can you hear me?
Yes, sir. Sir, I got your question, sir. Sir, actually, the vitamin D, those patients who were found to be deficient, we replaced them with a daily dose of vitamin D for 7 days, sir. Hello.
Can you hear me?
Yes, sir. Yes, sir.
Whether vitamin D was checked and corrected before surgery in both the group?
Yes, sir. Yes, sir, sir. It was corrected, sir.
Hello, ma'am. Can you hear us? Hello?
Yes, I'm able to hear you. Hello.
Hello.
She's muted.
Hello.
But you can hear.
Hello.
Hello, I'm able to hear you.
Yeah,
Hello.
I can hear the PGI as well as the conference center both. I think both are audible.
Sir, actually, I'm just answering that the vitamin D was replaced in those patients who were found to be deficient.
Yeah, I think you type it in the chat box also. The conference center is probably not able to hear you.
And now we can hear you.
Yeah.
So please answer.
Yes, sir. So vitamin D was replaced in the patients who were found to be deficient, sir. We gave them a daily dose of vitamin D, 60,000 OD for 7 days, sir.
Can we go to the next one, sir?
Please.
Okay. Dr. Joel Franklin, you can please share your screen. Dr. Joy?
Yeah. Is my screen
you can.
visible? Yeah.
Yes, please start.
Good evening, everyone. Today, the topic for my presentation is Fanconi syndrome due to monoclonal gammopathy, delayed diagnosis, and atypical features. Introduction: Fanconi syndrome refers to dysfunction of proximal renal tubule characterized by glycosuria, amino aciduria, uricosuriia, phosphaturia, and proximal renal tubular acidosis. Etiology of Fanconi syndrome in adulthood has limited differentials including myeloma, monoclonal gammopathy, amyloidosis, and drug or toxin exposure. Fanconi syndrome secondary to monoclonal gammopathy is due to proximal tubulopathy, which is either due to light chain proximal tubulopathy or heavy chain deposits, the former being more common. Here we describe our single center experience with 2 patients diagnosed with Fanconi syndrome associated with monoclonal gammopathy. And both patients initially presented to orthopedics department with the features of metabolic bone disease. Subsequently, endocrinology referral was obtained in view of hypophosphatemia. A urine examination and venous blood gas analysis pointed towards Fanconi syndrome. The workup of Fanconi syndrome lead to diagnosis of monoclonal gammopathy in both cases. And the clinical characteristics of the patients include, coming to case 1, She presented with a right foot pain, and MRI showed a stress fracture in the second metatarsal bone. And biochemical wise, urine analysis showed proteinuria, glycosuria, and ABG showed normal anion gap metabolic acidosis, and there was low TMP-GFR. And so we proceeded with the FGF1. FGF1 was 191. So then gallium dotated PET CT was done, but we didn't reveal any tumor, and hence we proceeded with kappa free light, kappa light chain assays, which was elevated, and then bone marrow aspiration and biopsy was done. Percentage of plasma cells in bone marrow aspiration was around 14%. And the final diagnosis of light chain myeloma was made, and the patient was started on cyclophosphamide, bortezomib, dexamethasone regimen. And here main thing is the hematological parameters was relatively normal. ESR was around only 7. Similarly, in the case 2, she presented with a bilateral hip pain, and MRI was suggestive of bilateral avascular necrosis of femoral head, and the venous blood gas analysis and urine examination was suggestive of Fanconi syndrome. But there was a low TMP-GFR, but here we didn't do FGF23 because during COVID time we couldn't outsource it, and then we proceeded directly to light chain assay. Again, the copper light chain was elevated, and here the percentage of plasma cells in bone marrow aspiration was around 1% only, and the bone marrow was suggestive of lymphoplasmacytic lymphoma, and the patient was started on bendamustine chemotherapy. And so this is a MRI picture of the case 2, which shows bilateral avascular necrosis of femoral head, and the renal.
Please conclude in 30 seconds.
The atypical and special features here includes both patients lacked hypokalemia at presentation. Hematological parameters were near normal at presentation. Patient 1 had elevated FGF23, which was later recognized to be of plasma cell origin. Monoclonal gammopathy of renal significance emerged as a diagnosis in case 2. Conclusion: Fanconi syndrome is a rare complication of monoclonal gammopathy. It can be the initial manifestation which clinicians should be aware of. Simple urine protein examination will give the clue to suspect Fanconi syndrome. Apparently, normal routine hematological parameters should not be deterrent for detailed workup directed at plasma cell disorders. Early diagnosis and initiation of chemotherapy will lead to marked improvement in quality of life and decreased mortality. Thank you.
That is a nice case. So in both the cases, the presentation was of osteomalacia.
Yes, sir.
And none of the cases presented with the routine features of myeloma.
No, sir.
There were no features of myeloma.
No features of myeloma at all, sir.
Right. Okay.
On routine workup, they had hypophosphatemia. That's why the orthopedics people called us, sir.
Right. Yeah, both of these are tricky cases. Yeah. Okay.
After treatment, renal parameters improved.
Yeah, it has partially improved, sir. It has not creatinine has not completely normalized. One patient is under 3-year follow-up, and another patient around 6 months follow-up. Both have partially recovered, sir. But symptomatic improvement is there's huge symptomatic improvement.
Okay, sir. So did these cases require phosphate replacement?
Yes, sir. On phosphorus and alkali replacement both.
Okay, right. Thank you.
Thanks.
Dr. Rohit Banabas, please share your screen.
Sorry, I am not able to see Dr. Modi. I can only hear his voice. His video is not coming.
My photo is not visible. That's what. Yeah. He has made yes.
Video.
I have kept
video
it
on, but there is some problem with the background, sir.
But I am not able to. Background only is seen.
Background, you can switch off the background, sir.
He has to switch off this IT person.
Okay, sir. Right, sir. No problem. Yeah,
slides visible?
Yes,
yeah,
yes.
visible. Am I audible and are my slides visible? Yes.
Yes.
Good evening. I will be presenting a case from KM Bombay. When you see metabolic bone disease, it usually causes debilitating clinical condition. And accurate diagnosis of metabolic bone disease usually leads to gratifying outcomes if the therapy. We present one intriguing and difficult case to diagnose and manage. There's a 52-year-old lady who had presented to us with progressive inability over 3 years. She was actually brought in stretcher. She was bed bound. She had generalized bony pains, knees, hips, shoulders, low back ache. She was treated with multiple therapies outside, with multiple physicians outside, with no improvement. One significant history was she had undergone the uterosigmoidostomy for ectopia about 29 years ago. She did not have any fractures or any other alternative drug history. When we evaluated her, we found that her calcium was on the lower range, 7.9. Phosphorus was low, alkaline phosphatase was elevated, and her chloride was persistently elevated. Her X-rays, when we did, showed thinned out cortices and thinned out bones. When we did urine was very difficult to collect because she had ureterosigmoidostomy. That still showed that there was calcium creatinine ratio elevated, urine pH of 5.8. When we went ahead and did other evaluation, we found that PTH was 32, vitamin D was 51, and her ABG persists consistently multiple, showed that there was metabolic acidosis with pH of 7.23. Her bone mineral density showed poor bone mineral scores, -5.3, -5, and -5. Ultrasound did not show any nephrocalcinosis. She had already undergone evaluation for secondary causes. There was no other secondary causes. Her electrophoresis, everything was negative. So workup for etiology of osteomalacia showed that she had severe osteomalacia, hyperchloremic metabolic acidosis with low phosphorus and calcium. She had increased urinary calcium creatinine ratio suggestive of calciuria, underlying ureterosigmoidostomy. So we finally concluded that she is having an acidification defect because of urinary diversion procedure leading to severe osteomalacia. So we decided to treat her with alkali only because we were not sure whether we should give phosphorus, but on doing literature search, we found that only alkali replacement is sufficient to improve phosphorus. So at 2 months, as we expected, she came back walking. She had 80% clinical improvement. She had biochemical improvement with calcium and phosphorus being 9.4 and phosphorus 2.8.
Please conclude in 30 seconds.
Had started reducing. Yes. So urinary intestinal diversion procedures, which can be anything from jejunum, ileum, colon, anything can be used, are not considered now because of multiple metabolic complications. They are known to cause increased fracture risk for almost 21% with a hazard ratio of 1.21. Osteomalacia is due to metabolic acidosis, hypercalciuria, hypocalcemia, and hypophosphatemia. The mechanism of defect is interesting. It is only reabsorption of acid from the intestine and nothing to do with the kidney. Intestinal acid is getting reabsorbed, hence there is acidification, hence causing osteomalacia. Hence only treatment with alkali suffices and phosphorus is not needed in this patient. Thank you.
Yeah, that was a nice case. What was the dose of alkali used in this case?
Sir, in our patient, we used potassium citrate. We used twice daily, about 1 to 2 milliequivalents, 1 milliequivalent per kg. With that, she had significant improvement.
Yeah, that is a really low dose. That's good.
Yes, sir.
Yeah, Dr. Modi, sir.
Yes. Actually, what type of metabolic acidosis? High anionic gap or normal anionic gap?
Sir, in this patient, we had a normal anionic gap metabolic acidosis we had, sir.
So, which alkali preparation you used?
Sir, we used potassium citrate. Yes, sir. Yes, sir. We used potassium citrate solution, as I've shown here, because the potassium was also low and patient had this ureterosigmoidostomy. So we decided to use potassium citrate solution, which was already available in this patient.
2 milliequivalent per kg. No?
Sir, in this patient, we used actually lower dose, 1 milliequivalent per kg, about 60 ml. With that, she was about 50-60 kilos. We used about 60 milliequivalent. That was sufficient for us. Her even pH had
was
improved.
monitored regularly. Potassium.
Yes, sir. Yes, sir. At repeat, I have not mentioned here. Potassium had normalized. Her pH had normalized. She actually came back walking to our surprise because because of the ureterosigmoidostomy, we could not really evaluate her urine parameters. TMP-GFR we could not do. So many things we could not do.
So basically, this is secondary RTA leading to osteomalacia.
Sir, this is actually intestinal acidification defect. The renal RTA component we can or cannot say, but this has been described in earlier procedures. It is mainly because of increased acid in the, in this case, ileum, which is getting reabsorbed in the body, and there is generalized acidification in the body, because of which there is calcium leaching from the bones, causing calciuria. Phosphate absorption is reduced, phosphaturia. 125 yes, 125 hydroxylate is suppressed, hence phosphate is reduced. That is the mechanism.
Thank you very much.
Dr. Rohit, what is the title of your abstract?
Sir, I wrote it as forgotten cause of osteomalacia because
Right,
this
thank
history
you.
was generally missed by everybody and we had to relate it.
Right, thank you. Thank you.
Thank you.
Thank
Dr.
you, sir.
Madhusmita, could you please share your screen? Dr. Madhusmita, are you there? Dr. Madhusmita? Okay, then we'll go to the next participant, Dr. Nayanthara. Dr. Nayanthara?
Yes, ma'am, I'm here. I'm sharing my
Sure,
screen.
sure.
Just give me a minute. Yeah. Is my screen visible, ma'am?
Not yet, it is coming. Yeah, it is visible. Please put it in slideshow mode.
Is it visible now? Hello, am I visible and audible?
Yes,
Yeah, it's
it is
okay.
not.
Go ahead. It's
Okay,
okay. You go ahead.
you
Go
can
ahead.
start.
Go
You
ahead.
can start.
Okay, good evening, everybody. I'm Dr. Nana from Department of Endocrinology, Ramchandra Institute of Medical Sciences in Chennai. So the title of my study is Milk-alkali syndrome. It's still currently relevant. So this is also like my previous presenter, it was a forgotten syndrome. So basically the introduction of the study goes this way. The introduction of the topic goes this way, that the milk-alkali syndrome is a triad of hypercalcemia, alkalosis, and AKI preceded by ingestion of large amounts of calcium and absorbable alkali. And this was predominantly present previously prior to the newer therapies which have been in practice now. Prior to this, when they were using a lot of magnesium alkali and for peptic ulcer disease, which led to large quantities of alkali being absorbed, and this was initially named as milk-alkali syndrome for the same. So here we present a case of a 45-year-old male who presented with complaints of decreased urine output, tachypnea, and altered sensorium to the ER for about 3 days. So he was recently diagnosed in his local village as a case of CKD along with systemic hypertension, and he was initiated on maintenance hemodialysis along with few medications that he had not told the ER person per se. He was also disoriented to time, place, and person. He was just conscious, but he was, however, disoriented. So he was at his hometown. He continued his maintenance hemodialysis at a lower frequency. He was told to get 3 hemodialysis per week. However, he had made it twice per week due to his financial constraints. On examination, he was found to be NSR. He was found to have NSRCA. And then frank fluid overload. His initial blood investigations are depicted. So on admission, if we see the corrected calcium is around 14.5. So the bicarb was 22. IPTH was sent because the calcium was elevated, and it was found to be 6. And creatinine was found to be 12.3. Phosphorus was sent in a fasting state the next day morning, and it was found to be 4.7. All other parameters were found to be normal. So as the patient was having acute renal shutdown, the patient had gone into anuria. In spite of being on CKD, the patient came in with fluid overload
Please
and disorientation.
conclude in 30 seconds. Dr. Naina, please conclude in 30 seconds.
Okay, ma'am, I'm done. So basically, this patient on deep history taking, he gave a history that he was on 4 grams per day of calcium carbonate for the past 2 months, and And in view of this, actually, we after ruling out all the granulomatous diseases, after reviewing the patient on physical examination and other laboratory parameters, and deep medication history review was done, and then we came to a diagnosis of milk-alkali syndrome. And here I would like to, I'm unable to move my slide, but I have a learning point. I am not sure if you guys can see it.
It is visible. Please conclude. It is visible.
Okay,
Yeah,
so the learning point here I would like to say is this syndrome has been renamed as a calcium alkali syndrome, which has become more common now because we're giving calcium carbonate, which is more financially better for the patient than the calcium citrate. So hence the patients tend to take calcium carbonate. Compliance is a little better with calcium carbonate because it's of easy availability even to the far reach rural areas, and they might end up with calcium alkali syndrome, and might have to keep this as one of our DDs when we consider hypercalcemia in a patient who's walking into
Time
the
is up.
OPD.
Time
And
is
the
up, Dr.
predisposition for this
Naina.
patient.
Yeah, we can go to the discussion, please. Sir, please ask your question.
So how much calcium was the patient taking? What was the preparation? Patient was taking
4
calcium
grams per day,
carbonate.
sir.
How
Yes,
much?
sir. Patient was taking calcium carbonate, sir, 4 grams per day, sir.
4 grams. Okay, that is really high. Right. So after that, what was the treatment initiated?
Sir, with just simple dialysis, the calcium came down, sir. As we can see in the table depicted, the post-dialysis at discharge was also normalized with just dialysis, sir. We haven't given anything other than dialysis as a specific treatment for milk-alkali per se.
Right. And was the patient on some vitamin D analog also, 125 dihydroxy or something?
No, sir. Thankfully, he was not.
Right. Thank you. Dr. Modi, sir.
So how much calcium carbonate you recommend for CKD patient as phosphate binder?
Sir, usually we go with a dose of 500 mg per day, sir. Am I audible, sir?
Yes, you are audible, but 500 mg if you use only as phosphate binder, along even if you are using calcitriol, then also it will be too less. Okay. Thank you.
She has one more. Don't you have one more presentation, Dr. Naina?
Yeah, I do. Just give me a minute.
Yeah, please.
Sir, it was probably the 4 grams
Isn't
of
your
calcium.
second case?
Sir, it was probably the 4 grams of calcium which kept the phosphorus at 4. Otherwise, her phosphorus also would have been 7 or 8.
Yes.
Can you see my screen?
No.
Are you able to see my screen now?
No, no.
Not yet.
Now?
Now it is coming. You continue.
Okay.
Yes.
So the next.
Yes.
Can start.
Please start.
So the title of this particular case report is Page's disease of bone and normocalcemic hyperparathyroidism, an uncommon association. So here we present a 64-year-old postmenopausal lady who came into the OPD with complaints of difficulty in walking, which developed following a fall at home 3 months before. She did not have any other comorbidities. So on clinical examination, we found a prominent scalp vein and frontal bossing. Initial investigations in a local hospital had shown a normal calcium, albumin-corrected calcium, along with, but however, there was a raised ALP that was present, which was 797 per se. So the parathormone was also the parathormone was done actually the patient was diagnosed to have a chronic illness and a CKD. So in view of the evaluation for the same, when they did a phosphorus and creatinine, and they had also done a IPTH, which was found to be elevated to be 2026. And so when the patient came into the OPD, we did an X-ray which revealed a left intertrochanteric fracture in the left hip, and she also gave history of 2 episodes of renal colic that required stenting and calculus removal 2 years before, which required intervention. In view of elevated PTH and normal calcium, a technetium testimony was done, which showed increased left inferior parathyroid uptake. For the elevated creatinine, her kidney size was assessed via ultrasound, and blood investigations were sent, which showed features suggestive of CKD. However, in view of her grossly elevated ALP, which was disproportionate for hyperparathyroidism, and clinical examination revealing prominent scalp vein and frontal bossing, Paget disease of bone was also considered. An X-ray skull, which is on the right side, is showing a thickened calvarium along with osteopenia that is observed in HPT. Hence, a bone scan was also done, which showed a diffusely increased in the uptake of the whole of calvarium along with vertebra, suggestive of a polyostotic PDB. Other contributing factors which could have caused the osteoporosis in this patient were hypovitaminosis D, postmenopausal state, and CKD osteodystrophy. So coming to the discussion part of it, Paget disease of bone is quite rare. However, the primary hyperparathyroidism is quite common, and a combination of both. Actually, Paget disease of bone can be associated with secondary hyperpara, but however, this case was associated with a primary hyperpara and an increased parathormone, which was contributing to the osteoporosis in this patient. So,
Naina, please conclude in 20 seconds.
Okay, as so we treated the patient with zoledronic. We could not give zoledronic acid, which is a choice of treatment in PDB, as the patient's creatinine was elevated. Hence, we gave denosumab, however, and we are still continuing to give denosumab. And now she's out of the stretcher and able to walk with a walking stick. She also underwent a left hip replacement surgery. Also was done under orthopedics, and we supported with calcium and other vitamin Ds before giving her denosumab. That's it, sir.
Can't it be secondary hyperpara? What was the parathyroid scan? You please tell what it showed. Parathyroid scan.
Sir, parathyroid scan showed an increased uptake in the left inferior parathyroid, sir. It is depicted in the right lower picture. Is it visible, sir?
Yes, it is visible. But are you sure that it is primary hyperpara? Can't it be secondary hyperpara with Paget's disease as a primary disease?
Sir, yes, sir. So for this, there has been an ISBMR review article that has been published in 2016, which goes with Paget disease of bone and secondary hyperparathyroidism. However, parathormone elevation is not this significant, sir. The parathormone here is 2000 odd, sir. In that, they have mentioned up to a subtle levels of elevations of PTH, and not to this extent of hyperparathyroidism.
PTH will be sky high in secondary hyperpara, not in primary hyperpara. It will be very high in secondary hyperpara.
Okay, sir. I think I got it wrong then.
I think, no, I'm not sure whether you are wrong or not. You might be right after all. Our job is just to show you the other point of view also. I think Dr. Modi is right. If you see cases of secondary hyperparathyroidism like vitamin D deficiency or CKD, you will find PTH in the range of 400 or 500. While in primary hyperparathyroidism, PTH might be only 70 or 80 nanogram per ml. Sorry, 70 or 80 picogram per ml.
120.
Yeah, so I think that is right. But anyway, your case is interesting. It might still be primary hyperparathyroidism. I cannot argue on this point right now. Case is interesting. Thank you.
Thank you.
Thank you. Next would be Ms. Simran Kaur. Will you please share your screen? Ms. Simran Kaur.
Yes, ma'am. My screen visible?
Yes, visible. Just make it slideshow and you can start.
Good evening, everyone. I am presenting my work titled
Third one is not.
It's coming.
She's coming next.
Simran, are you there?
Yes, ma'am.
Time is running out.
Please start.
Please continue. Time is running out.
Ma'am, my screen is visible?
Our screen is visible.
It is visible. You please start.
Okay, good. Good evening, everyone. I am here to present my presenting my work titled "The Expression Analysis of MIR-656 and Inhibitory Effect in the Postmenopausal Osteoporotic Women." Postmenopausal osteoporosis is the bone metabolic disease in which the bone resorption is increased due to the low level of estrogen and increased age. MicroRNAs regulate bone formation, resorption, and remodeling process. In this study, we analyzed the expression of circulatory microRNAs in the serum of postmenopausal osteoporotic subjects. Initially, the microarray of microRNAs was performed, and we found around the 300 differentially expressed microRNAs, and we select the significantly highly expressed microRNAs MIR-6565P and MIR-148-5P. And after that, the microRNAs were further validated by the qPCR, and we found that the MIR-656P was significantly downregulated in the osteoporotic patients, and MIR-148 was upregulated in the osteoporotic patients. After the qPCR validation, we further found the target of this specific MIR656 microRNA by using the target stand. We found that the tumor necrosis factor is the direct target of 656. Tumor necrosis factor is promote the bone resorption by increasing the level of RANKL, which involved in the osteoclastic activation pathway. After the target prediction, we further analyze the pathway of targeted gene by using the online tool string.
Simran, you have to conclude in 40 seconds, okay?
Which showed that it involves in the osteoclastic signaling pathway. In conclusion, we found that MIR655P was downregulated in our study, and we found that TNF is the direct target of MIR655P. And we would say that if we upregulate the expression of this microRNA, it would regulate the RANKL-mediated signaling pathway. Thank you.
So, what were your subjects?
Post-menopausal osteoporotic women and age-matched healthy control.
And you had ruled out all the secondary causes.
Sorry, sir. Yes, sir. Yes, sir. Only primary osteoporosis.
Okay, sir. Dr. Modi, sir.
What could be the clinical implication of your work?
Sir, as we found that the TNF is the target of this microRNA. If we increase the expression of this, the expression of this microRNA is lower in the osteoporotic patients. If we would increase the expression of this microRNA, it will further target the TNF factor, which include in the osteoclastic activity. So the osteoclastic activity decrease.
Thank you.
Thank you, sir.
Dr. Roshan Nasruddin can share this screen.
Yes, ma'am.
Daljit sir. No, sir.
Simran Kaur, please mute yourself.
Good evening, everyone. I will be presenting an interesting case of infantile onset brittle bone disease. Multiple recurrent fractures in childhood may be due to a primary bone condition or secondary to factors like muscular dystrophy or endocrine conditions like hyperparathyroidism, hypercortisolism, or drugs like corticosteroids, or even child abuse. Osteogenesis imperfecta is characterized by decreased bone fragility due to mutations in type 1 collagen with an estimated incidence of 1 in 20,000 live births. It may be associated with various extraskeletal manifestations. Here we report a case of a 7.5-year-old boy presenting with multiple fractures since the age of 1 year, following normal daily activities, about 3 to 6 fractures per year, which was treated by local bone setter. There is no history of any hearing or visual impairment or malabsorption, malnutrition, recurrent respiratory infections, or any systemic illness or chronic drug intake. There was no similar family history. Examination had revealed the cubitus varus deformity of the left upper arm, scoliosis, and bilateral genovalcum. The stature was normal for the age, and there was no blue sclera or dentinogenesis imperfecta. X-ray revealed multiple fractures involving the diaphysis of the long bones, and the routine investigations were normal. The serum calcium, phosphorus, vitamin D, alkaline phosphatase, and intact parathormone levels were also normal. A clinical diagnosis of osteogenesis imperfecta was made, and he was treated with zoledronic acid infusion, 0.05 mg per kg once in 6 months, along with calcium and vitamin D supplementation. Following this, over a period of the next 2 years, there were no further fractures, and there was significant symptomatic improvement. Since our patient has presented with multiple deforming fractures without any extraskeletal features or blue sclera, this is probably a case of moderate, clearly severe osteogenesis imperfecta, probably type 4. And as there is no family history, it could be due to a de novo mutation. To conclude, osteogenesis imperfecta is a potentially treatable cause of recurrent fragility fractures, which should be kept in mind and appropriate diagnosis and incision of bisphosphonates will significantly improve the outcome and quality of life. Thank you.
So patient did not have any other manifestation, no deafness and no teeth abnormality?
Yes, no sir, no other features were there, only fractures were present.
And there was no history of intrauterine death also?
No sir, no history in the family.
Patient was followed for how long after starting anti-resorptive therapy?
2 years. Now for 2 years he's on follow-up.
Right, thank you. Dr. Modi sir.
So you don't think any genetic study is required in this case?
Yes, sir. Actually, genetic study is required, but as he had responded well with treatment and due to affordability problem, we have not yet done. We are planning to do it.
Thank you.
Thank you.
Yes.
Thanks.
Okay, so we have concluded the third session. We will go to the fourth session. Am I audible? Am I audible?
Yes, you are audible.
Am I audible?
Yes, you are audible.
Yes, sir. Good evening, sir. Dr. Ashish, sir. And good evening, ma'am. Dr. Sridevi, ma'am. So we'll be starting with the fourth session of posters. So the first presenter would be Dr. Likita. Staff presenter.
Good evening, everyone. I'm Dr. Likita, resident from SWIMS Tirupati. We have a couple of cases of a rare presentation of juvenile hyperparathyroidism. These both cases were pubertal and were referred to us from an orthopedic department where they were being treated as a vitamin D deficiency ricket because of their low vitamin D levels. The case one was a 13-year-old boy who was complaining of inward bending of his knees with genovalgum for a duration of 2 months. That is a short duration period. And the deformity is progressive and associated with mild knee joint pain, and he has short stature with a height DSG of minus 3.73 SGS and an intermalleolar distance of 16 centimeters with scoliosis. And his serum calcium was 12.2, which was on the higher side, and a phosphorus of 2.6 and an elevated ALP of 4,280. As his vitamin D levels were low, he was given vitamin D supplements and was being followed up because of without any much progress in the clinical scenario. He was being referred to us. So we got the repeated serum calcium without any tourniquet, but it was still on the higher side. We got a serum PTH, but never hyperparathyroidism was on our mind. And on a sesame MIBG scan, it showed a right inferior parathyroid adenoma. And he was operated for hyperparathyroid adenoma. The second case is also a similar case, the pubertal age of a girl who presented with a similar complaints of short duration for the 6 months, and she has severe proximal muscle weakness, and the height is also less than minus 3 SG and an intermalleolar distance of 18 centimeters. Her calcium was on the higher side, 12.7 with a phosphorus of 2.2. And the PTH was 978 picogram per ml, and the MIBG scan showed uptake in the left inferior parathyroid adenoma. Both these cases we evaluated for men, and their urinary metanephrin and non-metanephrin were normal. There was no family history of any previous surgeries in their family or any cancers in their family. After operation, the HP report in both these cases was consistent with benign parathyroid adenoma. Post-operatively and even during interoperative 5 minutes after the excision of the glands, there was a drastic decrease in the PTH levels. In the first case, it was 165, and the second case was 176. That is more than 50%, obviously. And after 3 months of follow-up, their levels normalized, normal calcium, normal phosphorus, and PTH was 19 and 13 in both the cases. The post-operative period was quite uneventful. We didn't have any hungry bone syndrome, and they were discharged on calcium carbonate and vitamin D supplements. So to discuss this case, hyperparathyroidism, primary hyperparathyroidism is very uncommon in juvenile cases. While it has an incidence of 27 to 30 cases per 1 lakh in adults, while it is only 2 to 5 per 1 lakh in children. And the clinical spectrum is also very vague, non-specific, with the symptoms of hypercalcemia. Genovalgum per se is only seen in up to 12 cases in juvenile hyperparathyroidism, and this is very uncommon. And this is mostly seen in children who are pubertal because of direct effect of PTH on growth plate, or it may cause a growth spurt resulting in genovalgum. Thank you.
So, did you think of doing a genetic test? You said you have investigated for men. How did you do that?
We just asked for a history, and we did prolactin levels, and we got 24-hour urine metanephrines and normetanephrines in both the cases, ma'am. And both of those were normal, showing that there is no pituitary or adrenal pheochromocytoma involvement as in men 1 or men 2. We couldn't get the genetic analysis as the patients were unaffordable financial constraints.
Okay, but
actually the boy had a pain in the jaw, so we suspected it could be any hyperparathyroid jaw syndrome, and we got a optopantogram, and that was normal. So it was just eruption of his wisdom tooth, I think, that caused the pain.
okay, so what do you think are the indications for doing a genetic test in hyperpara?
Hyperpara, it is a symptomatic hypercalcemia with the hyperplasia of all the 4 glands instead of adenoma of 1 gland, or young age of onset less than 20 years or 35 years, and a positive family history, any one member having similar complaints at an younger age. And it's most common females, while the hyperpara is common in males.
Okay. So maybe doing a genetic test here would be beneficial, because you might have some familial syndromes also, apart from the jaw tumor thing. So if possible, they do a genetic test for quite less amounts, like around 10 to 11,000. If your faculty members, Dr. Alok Sachin or somebody, can speak to them, they can get it done. Okay.
Sure, ma'am. They're still being followed up. They were recently operated. I'll get it done. Sure.
Yeah, and it's a nice case. Good presentation. Thank you.
Thank you, ma'am.
So what is the impact of treating these conditions on the deformities? So have you searched in
The deformities have been improving quite a lot, and the intermalleolar distance, as you can see in the picture, the X-ray was the preoperative one, and the guy standing behind was post-operative. And even his day-to-day activities have been very better. He was able to walk around, cycle, and his proximal myopathy was decreased a lot. And the intermalleolar distance has come to 6 centimeters, and they are both doing quite good as per the Genova algorithm.
So what are the other familial or genetic causes of juvenile hyperpara?
You are suspecting MEN1, MEN2B, or any mostly.
Okay.
Thank you.
Thank you. Next presenter would be Dr. Priyanka. Dr. Priyanka, please share your screen.
Yes, ma'am. Ma'am, since the other participant is sharing,
Yes, please share.
Good evening, everyone. I'm Priyanka, postgraduate in DM Endocrinology, Madurai Medical College. Here I am discussing the various varied presentation of primary hyperparathyroidism. The first is a 17-year-old female who presented with limping gait. On presentation, she had a high serum calcium and a low phosphorus level, with a very high PTH and adequate vitamin D levels. So USG neck revealed a 3.4 into 2.9 hypoechoic lesion in the inferior pole of the left thyroid, with skeletal survey showing characteristic skeletal lesion. So patient underwent parathyroidectomy. Post surgery, even after day 5, patient had severe hypercalcemia with low phosphorus, low magnesium. Diagnosis of hungry bone syndrome was made. So initially patient was on IV calcium. She also required calcitriol and oral magnesium, and it took almost 6 months for the patient to totally improve. The next is it's a 42-year-old male who presented with pain and inability to use both the lower limbs. He presented with diminished sensorium. He too had a very high PTH with a high calcium, low phosphorus level. In his USG neck showed a large hypoechoic lesion in the inferior pole of the left thyroid. Here he had characteristic skeletal manifestation with fracture of multiple ribs and fracture neck of femur. And since the patient presented with acute hypercalcemic crisis, we treated it with adequate hydration, zoledronic acid, and cinacalcet tablet was also required. After the acute crisis was subsided, the patient was taken into surgery on table because of a hard lesion and firm adherence to the tissue. There was a suspicion of malignancy. So left hemithyroidectomy with parathyroid dissection and central node dissection was made. Histopathology confirmed the parathyroid carcinoma with capsular and vascular invasion. However, there was no metastasis. And since no patient was not affordable, genetic testing could not be done. The next is a 54-year female who presented with swelling in the right side of the cheek. She also had a high calcium with low phosphorus and a very high, and a high PTH level. So there was a lesion in the left lobe of the intense MIBG uptake in the left lobe of the thyroid gland, and there was an expansile lesion the right half of the thyroid, which was the brown tumor. And so biopsy of the mandibular mass showed Jane cells, confirming the diagnosis. Patient underwent parathyroidectomy. After this, the patient was under follow-up, and the mandibular mass decreased in size gradually post-surgery. Now she is 6 months post-surgery, and the mandibular mass has completely disappeared. So though the asymptomatic variety is common in the Western world, here there are varied manifestations. Thank you.
Two minutes for discussion. So, ma'am.
Yeah, interesting cases again. Yeah, it is quite well known about the varied presentations of hyperparathyroidism. So again, question of genetic testing, and did you also do an intra-op PTH?
No, ma'am. We were not able to do an intra-op PTH, ma'am. But post-operatively, we actually did 24 hours post-surgery. It was actually less than 50%. It was suppressed.
So what would the follow-up of parathyroid carcinoma be?
Ma'am, recurrent hypercalcemia is very common in parathyroid carcinoma. So we should hypercalcemia should be followed up regularly. And if there is an recurrence, so we should also look for any recurrent tissue or a mets, or presence of mets.
Is there any other role of radiotherapy or chemo in parathyroid carcinoma?
The main surgery is the main treatment, ma'am.
Yeah,
but
so yeah, not much role of radio.
Not much role of radio and chemo.
So, do you have any other atypical presentations of primary hyperpara?
Yes, sir. It can be normocalcemic.
Yeah.
Normocalcemic hyperpara.
And usually ectopic. Usually parathyroid are more common when they are ectopic.
Yes.
Okay. Yeah. Okay.
Okay.
Thank you. Next will be Mr. Chirag Kulkarni. Please share your screen.
Hello.
Yes.
Yes,
please share your screen.
Yes. Just a second, I am sharing my screen.
Yes.
Is my screen visible?
Yeah, now it's visible.
Yeah.
Yes, visible.
Good evening to all. My name is Chirag, and my topic of presentation is assessment. Sorry.
Please put in slideshow mode.
It is in the slideshow mode only. Is it not visible?
It's just visible as a slide mode only. Okay, you can go ahead.
Now? Is it visible now?
Not yet in the slideshow mode. It is just seeing as a slide. No problem. No problem. You can continue. It is visible otherwise. You can continue.
Okay. Good evening to all. My name is Chirag Kulkarni, and my topic of presentation is assessment of a novel camphoral enriched extract of tea in osteopenic rats. Here we have utilized the novel extraction method to enrich the camphoral amount in the tea extract and subsequently decrease the amount of EGCG, which is a hepatotoxic, which is reported to be a hepatotoxic. And we have used both these extract, that is hydroethanolic extract and the camphorol enriched extract, to check their efficacy in the fracture healing study. So in the second panel, you can see that the camphorol enriched extract, I will give a short description of fracture healing. We create a fracture by drill hole in the femur of rat and give the dose for 12 days. And after 12 days, we do micro CT and also calcium labeling. After 12 days, we have found that the fracture healing was the camphorol enriched extracts have promoted new bone formation at the osteostomy site, whereas the hydroethanolic extract has no effect. And at all the three doses, 100, 150 and 200 mg per kg dose, the camphorol enriched extract have shown significant new bone formation. So we have selected the 100 mg per kg dose in the osteoporotic model and in the rats only, Sprague Dawley rats. And we have done bilateral osteoporotic model by creating bilateral ovarectomy and given the dose for 4 months. And after 4 months, we have checked the increase in the fat mass. The extract has significantly prevented the OVX-induced increase in the fat mass. Later, we have checked the osteoblast differentiation by mineralization. Here also the extract has significantly promoted the mineralization capacity. And we have checked the LFT to check whether the extract have hepatotoxicity or not. Here we have found no hepatotoxic effect, whereas the EGCG, the normal extract, EGCG have hepatotoxic effect. Later we have checked micro-CT parameters also, and we have found in all the parameters of femur trabeculae, tibia trabeculin, or also L5 vertebrae, the extract have significantly prevented the OVX-induced bone loss. Later we have also checked the bone PINP, serum PINP, and we have found that the extract has significantly prevented the reduction in the PINP level and also significantly prevented the increase in the TRAP level and also Rankel OPG ratio. Later we have also checked the new bone formation by surface reference bone formation by calcium double labeling. Here also the extract has significantly prevented the mineral surface by bone surface and also bone formation rate comparable to the sham group. Then we have checked the bioavailability by single dose of extract, and we have found that the plasma bioavailability was 2 micromolar. Hello, am I audible?
Yes, you can.
Hello. Yes. And at that 2 micromolar dose, we have checked in vitro osteoblast differentiation, and at the 2 micromolar dose, the extract has the camphorol has significantly promoted osteoblast differentiation. So the overall conclusion of my study is that the 100 mg per kg dose of camphorol enriched extract have significantly prevented the loss in the bone microarchitecture and bone mass in the OVX rats by osteogenic mode. And also it has no hepatotoxic effect, and it has sufficient bioavailability of camphorol. So we recommended it for preclinical trials as it is a therapeutic candidate for treating postmenopausal osteoporosis. Thank you. That's it, sir. Thank you.
Yeah, the pause is because we have quite less knowledge about this, and it seems to be something quite novel.
Ma'am, I can explain how we can create the model. If there is a time, I can explain that. The fracture model is created by creating a drill hole of 0.8 mm in the femur diaphysis and treated for 12 days. Here we have bone formation, and the OVX model is created by bilateral ovarectomy. And after 7 days, we have given the dose in the preventive manner, not therapeutic. In the therapeutic, we create osteopenic rats by keeping the rats for 3 months after ovarectomy and then give the dose. Here we have given in the preventive manner.
So how did you come upon this? It's there in all the teas, or is it some specific tea?
No, green tea. It is a green tea. So there is a green tea means consumables. There are very much consumables of green tea, and it has they are used for the osteoporotic treatment. But all the green tea have EGCG, that is catechins, which have been reported to have hepatotoxic effect. So the overall idea is to use the green tea reduce the amount of catechin and enhance the amount of camphorol, which is already present in the green tea only. And it has hepatoprotective effect. It has been reported to have hepatoprotective effect. So it is a natural component of the tea. So we have utilized it.
Okay.
What about was any calcium levels or vitamin D levels evaluated before?
Yes, sir. We have checked the calcium phosphate comparable to the sham group, and there was no change in the treatment, as there is no change in the hypercalcemic condition or any other condition by giving the extract.
Okay. And was it osteopenia, matlab etiology, was it same in all the rats?
So what he's saying is, did you check for other causes of osteopenia in these rats, like vitamin D deficiency and calcium supplementation? Was that all checked before?
It is a model for estrogen deficiency only. It is an established model for estrogen deficiency only.
Okay. No, but how did you rule out other causes? That's my question actually.
Because all the rats were kept at the same condition only. All the rats were brought together only. All the rats were treated means at the same time only, and then were distributed after 8 days.
Do you do any basic investigations for any tests before for these rats?
In the therapeutic dose, in the therapeutic dose, we do the test. We do primary microcity in the baseline. We all we do microcity of all the rats in the baseline, and after 6-month treatment, we also do the microcity. But in the preventive group, we don't do, because it is not a that technique. We have to compare the initial and the final.
Time is
results.
over for discussion. Could we conclude?
Okay, thank you.
Thank you.
It's a good presentation, Dr. Chirag. Okay.
Thank you.
It's a normal thing, so we have to see.
Thank you. Dr. Moomin can share the screen. Dr. Moomin? Dr. Moomin, are you available? Okay, we'll go to the next person. Dr. Jeeban Pradhan?
Yeah, I'm available, but I'm not able to share. Just 1 minute.
Okay, so we'll give you the next chance. Dr. Jeeban Pradhan, please share your screen. Dr. Jeeban?
Yes, I'm starting, sorry. I'm starting. Hello, is it visible?
Yes.
So, good evening, everyone, respected judges and all delegates. I am Dr. Jeevan Pradhan from Department of Endocrinology, SCB Medical College. I am going to present us about a spectrum of hypomagnesemia that we got in the last 2 years in our institute. So magnesium is the second most abundant intracellular and fourth most abundant extracellular cation in the body, but hypomagnesemia doesn't get the appropriate attention as others like hyponatremia, hypokalemia, and hypocalcemia. But magnesium is really required for all the many enzymatic reactions requiring ATP, various reactions requiring kinases, neuromuscular excitability, and cell permeability, and regulation of ion challenge and mitochondrial function, and cellular proliferation, apoptosis, immunity, and among many others. So in this study, the clinical and biochemical profile of the patients with hypomagnesemia admitted to our institute was evaluated, and the case we did this by just going through our case records of the last 2 years, and data was compiled and analyzed. So most of them were in their we got around 18 cases due to various presentations, and most of them were in the age group of 30 to 40, both females and males. And the most common presentation was tetany due to hypocalcemia, and when we went ahead and evaluated the cause, was actually they were resistant, and we found out to be having hypomagnesemia associated with it, and also many of them presented with hypokalemia, which was not referred from other departments, which was not corrected by supplementation with potassium, and they referred us for further evaluation. And uniquely, 2 of the patients were of postpartum period, and referred to us from gynec department for development of tetany. And on further evaluation, we found that the main cause of root cause was due to hypomagnesemia, and after correcting hypomagnesemia, there was dramatic improvement. And we also got 2 cases of Graves' disease, which were recently detected and were severely thyrotoxic, and presented with, as one presented with periodic palsy and other with hypocalcemic tetany, and on routine evaluation we found out to have hypomagnesemia. And 4 of them also had diabetes mellitus, and during correction of their severe hyperglycemia during infusion, they developed tetany, and we attribute and were found to have be hypomagnesemic, and we could attribute that most likely the cause was due to hypomagnesemia.
Time up, Dr. Jeevan.
Okay.
Please conclude.
So most common cause was due to renal losses, and second due to intestinal losses in few patients who presented with diarrhea and subsequently developed tetany, and due to redistribution in case of those patients with decay, and a few patients with Graves' disease. So there is no specific targeted therapy but currently available, but routine corrections of underlying etiology and metabolic derangement is very essential. And routine awareness and dietary supplementation of magnesium is also necessary, as we do for calcium and vitamin D and other electrolytes. We should also focus on magnesium, and because this chronic hypomagnesemia
Can't hear you.
intracellular, they may cause various complications like increased risk of cardiovascular diseases and increased risk of heart failure and different arrhythmias. Thank you.
So what would you suggest, doctor, regarding the inpatients? Do we actively look for hypomagnesemia, and how do you think this study has helped you in treating your other patients, the new patients that you are admitting?
Okay, actually, this helped because routinely now, whenever we look into hypokalemic patients, we do look into magnesium at the first go itself, and also patients with tetany who are present in them also, we do not miss whether magnesium is adequate and has been supplemented. And after getting a few of these cases, we also started in which patients of diabetes also we suspect them also, we started to look for magnesium levels. And pregnancy itself is a hypomagnesemic state, and in our country many of the women they are at the brink of manifesting clinically. But during pregnancy or during lactation, when another disease is added upon this, like one presented with Graves' disease, so pregnancy, lactation, then upon that Graves' disease, that also precipitated that chronic hypomagnesemic state in them. So it made us a bit aware of the different clinical scenarios where the patients may be at chronic hypomagnesemia, not particularly hypomagnesemic, but intracellular magnesium will be low, very low, and they will be just at a balanced state, and they may at any moment go into precipitate into hypomagnesemia and various.
Time up for the discussion, ma'am.
What are the factors which affect magnesium levels in a hospitalized patient?
Sir, factors which mainly the nutritional state, and if any acute intervention is done, like IV fluids, IV parenteral nutrition, mainly ICU bound patients, they are more prone for hypomagnesemia.
Yeah.
And
in EPN, so they can have these electrolyte disturbances. Probably if you have stratified them into stable patients and critically ill patients, it would have a much more impact.
Okay, sir. Thank you, sir.
We have next participant, Dr. Momin. Please start sharing your screen. Please stick on to time.
Is it visible?
Yeah.
Good evening. My name is Dr. Momin. I am going to present pancreatitis as a complication of primary hyperparathyroidism. As we know, primary hyperparathyroidism is the third most common endocrine disorder in the West.
Please keep it in slideshow mode, Dr. Momin.
And PHPT has been linked with both acute and chronic pancreatitis since the mid-20th century. The first report dates back 1940 by the Smith and Cook, but the true association between the PHPT and pancreatitis continues to be controversial. The aim of our study was to compare the clinical and biochemical profile and management of PHPT patients who had pancreatitis as compared to those PHPT patients without pancreatitis. Material and methods. This was a retrospective study that included 250 consecutive cases of PHPT diagnosed and managed at our center over a period of 24 years. All patients had sporadic PHPT, and patients with diagnosis of men were excluded from the study. The records were reviewed for age, sex, and laboratory data. The laboratory data included measurement of serum calcium, phosphate, alkaline phosphatase, PTH, vitamin D, albumin, urinary calcium. The diagnosis of pancreatitis was entertained in the presence of at least two of the following three features: abdominal pain, serum amylase levels more than 3 times, or characteristic features at the imaging. The results were that among 250 patients with PHPT, 17 patients had pancreatitis. That's 6.8% of the cohort. 16 out of the 17 patients had acute pancreatitis, and 1 patient presented with chronic calcific pancreatitis. 8 out of the 17 patients had at least 2 episodes of the pancreatitis, and pancreatitis was the presenting symptom in 15 out of 17 patients, while 1 patient developed post-operatively, post-parathyroidectomy, the patient had pancreatitis. None of the patients had an additional risk factors for pancreatitis, such as gallstones, alcohol abuse, or hypertriglyceridemia. Once the biochemical features are compared between those who had pancreatitis with those without the pancreatitis, it was found that serum calcium was significantly higher in the PHPT patients, and serum ALP levels were also significantly higher in these patients. The rest of the biochemical features were similar between the two groups. In 8 patients, pancreatitis was the sole manifestation of the PHPT without evidence of classical organ complications like kidney or bone disease, while 9 patients had other classical complications in the form of skeletal and nephrolithiasis. After successful parathyroidectomy, none of the patients except 1 had further attacks of pancreatitis during a median follow-up of 16 months, which ranged from 2 months to 41 years. This table shows the characteristic features which are similar between the two groups, except for the serum calcium, which was significantly higher in the pancreatitis group, and serum ALP levels. The rest of the biochemical features were similar between the two groups. So to conclude, the pancreatitis can be the only presenting complaint of the PHPT patient. Our study highlights the importance of fully investigating for PHPT in any pancreatitis patients with high normal or raised serum calcium, especially in the absence of other common causes of pancreatitis. Thank you.
So how many of these patients had an endocrinologist referral?
Actually, madam, it was a retrospective cohort. They were all referred to us. It was a departmental records that we analyzed, and out of those, 17 patients have pancreatitis.
So would you now recommend that they do serum calcium in all the pancreatitis patients?
Yes, ma'am. It is otherwise the routine in our hospital protocol that we do the calcium levels in all the patients who have the pancreatitis.
Yeah. So I think that is a good point where most of our gastro colleagues might not do. But doing a calcium is basic, and even in kidney stone patients also, so many patients do visit the urologist, but never is a calcium done.
Yes, ma'am.
So it was a good retrospective study.
Thank you.
Very good study, more relevant to our daily practice. And is pancreatitis common in normocalcemic primary hyperpara?
Actually, the true association is there are few studies where they have seen pancreatitis in the PHPT, and in all the features, in most of the studies, they have seen the serum calcium was significantly higher in the cohort that had pancreatitis. So actually, most of the literature shows that there's a high calcium that actually causes pancreatitis rather than the PHPT itself. So by that, sir, in our patients, all the patients had high calcium levels. None was in the normal calcemic group.
Duration of the disease, will it affect the course of primary hyperpara? Matlab, long duration, maybe more chances the patient may develop pancreatitis.
Yes, sir. So we had 3 patients out of the cohort who had 4 episodes of pancreatitis. Because of the illness, we could not do the surgery at an earlier date. And they sometimes are very sick patients where we cannot, we have to wait for the pancreatitis to resolve. 3 of our patients had 4 episodes of pancreatitis before they were diagnosed actually as a case of PHPT.
Okay, but everybody had adenomas only?
We have 2 patients who had ectopic. One was introthyroidal and second was mediastinal. That had single adenoma.
Okay. Okay.
Time is over for discussion.
Thank you.
Thank you.
Next, we have Dr. Kirtana Nair. Please.
Yes.
Dr. Momin, please unshare.
Please share your screen, Dr. Kirtana.
I'm just sharing. Is my screen visible, ma'am?
Yeah. Yes. Please make it in the slideshow.
Yes. Good evening, respected judges. I am Kirtana from the Department of Endocrinology, PGI Chandigarh, and I'm presenting the study, which is an assessment of treatment satisfaction, adverse effects, and out-of-pocket expenditure of 3 parenteral drugs, which are denosumab, teriparatide, and zoledronic acid, which are commonly prescribed for osteoporosis. So previously conducted studies in the Western population have shown that there's a higher preference for parenteral therapy as compared to oral therapy due to lower number of adverse effects, convenient dosing schedule, and no complex postural requirements for parenteral therapy. Hence, we conducted this cross-sectional study to understand these parameters from the patient perspective in the Indian population. So for this study, we screened a total of 210 participants and enrolled 48 participants who were radiologically confirmed with osteoporosis and on therapy with either of the 3 drugs. So we found that, 50% of the participants had been on therapy for more than a year, and other clinical characteristics, among other clinical characteristics, we found that 20% of the participants, which was 9 out of 48 participants, reported having a family history of osteoporosis, and 8% of the participants reported having sustained a fragility fracture in the last 1 year. And comorbidity score, which I presented as mean scores calculated using the Charlson's comorbidity index, was highest for the users of teriparatide. And now coming to the satisfaction scores, which I've collected using the validated treatment satisfaction questionnaire for medication, we observed that the mean satisfaction scores were highest among the users of teriparatide, and the users of all the 3 drugs found the drugs to be convenient, which is observed by the high mean satisfaction scores in the convenience domain. And the maximum number of adverse effects reported by the patients were belonging to the musculoskeletal and connective tissue systems, and followed by the gastrointestinal disorders. And now coming to the cost, the median 1 year out-of-pocket expenditure was highest for the users of teriparatide, and the bulk of the expenses was due to the medical costs, which included the cost for medication and the cost for laboratory tests, with only the travel cost, which was to and from the clinic, which was contributing to the direct non-medical cost. Another important finding of the study was that approximately 17% of the total participant screen, which was 35 of the 55 ineligible participants, had discontinued treatment,
which highlights the need for further studies that explore the adherence and reasons for discontinuation among the patients of osteoporosis taking parenteral drugs. And lastly, I would like to acknowledge the study participants who visited the OPD and contributed to my study, the Indian Institute of Public Health Delhi and the Department of Endocrinology, PGI Chandigarh. Thank you.
You said that many people had discontinued. So which treatment was the highest in terms of discontinuation?
Ma'am, since the participants that have recruited in my study, since the numbers are not equal that I got, so I won't be able to conclude which treatment per se had more discontinuation.
Discontinuation, okay. And so the patients who are on denosumab, are they continuing to take denosumab, or they have stopped and then you had to switch over to something else?
There were a few patients which had reported having switched, but a lot of patients, I did find that they had discontinued treatment. So since that was not an objective of my study to explore the reasons for discontinuation, we did not explore that.
So in the denosumab group, those who have discontinued, were you seeing more fractures, rebound?
Actually, I did not explore.
Okay. So is there a cohort in this wherein you have used teriparatide for a while and then started on some other like zoledronic acid to continue? Or is it only purely each drug individually?
Ma'am, in this study, I've only explored each of the drugs individually. So I did not collect if the patients had switched over to other drugs.
Did you also see whether any of these people had compliance issues with calcium and vitamin D?
Ma'am, I did collect that they were on calcium and vitamin therapy, but I did not look at the compliance of calcium and vitamin.
Okay.
So why do you think more people were satisfied with denosumab when compared with other treatment preparations?
So what I observed was the more number of patients on denosumab reported lower side effects, and they found it more convenient as compared to teriparatide, which was a daily. Sorry, sir.
Okay, go on.
Yeah, so they found it more convenient as compared to teriparatide, which was a daily injection. And since the number of zoledronic acid patients in my study were very less due to restrictions in the physical OPD due to COVID-19, I was able to find only these many patients.
What was the duration of the study?
So it was 6 months.
6 months. Any bone toner markers were done?
No, sir, I did not collect bone toner markers.
And like, have you randomized which patients have to receive denosumab, teriparatide, or zoledronic or something like that, or it was just an observational?
So this was an observational study. Since we were not comparing the 3 drugs, then we only collected the data individually for the drugs.
Oh.
Don't you think if you have done it only for 6 months, denosumab had an unusually higher advantage?
Yes, ma'am. This was what we observed in this study.
Even zoledronic acid also, because zoledronic acid also you'll be giving once in a year, and denosumab once in 6 months, and teriparatide you'll give daily, right?
Yes.
Yeah, longer duration of study would have actually helped. Maybe
Yes.
at least.
Yes, sir.
So maybe you should think of continuing it and doing it after a year or 2.
Yes, ma'am, definitely.
Yeah.
I think a longer duration will definitely add more to the data.
Yes. Thank you, Kirtana.
Thank you so much.
We have the last presenter, Dr. Angad Kumar. Judges, please note, actually he was included in the first session, but due to technical difficulties, it couldn't happen. So his name is not included in the... Am I audible?
Yeah, Sumaya.
Yes. Actually, his name has to be included in the scoring sheet, ma'am and sir. Dr. Angad Kumar, because he was initially in the first group, so his name will not be there in the current judgment sheet actually.
There are actually no names in the judgment sheet that you have given. It's only the case. There are no names. It's only like.
Am I audible and my slide visible?
Your slide is not visible.
Sir, now sir?
It's still not visible.
Dr. Angat?
Yes.
Please share your screen.
Yes, just a minute. Is it visible now?
Yeah. Yes. Please put in slideshow mode.
Just a minute. Final now. Yes. Good evening, everyone. Am I audible?
Yes.
Good evening, everyone. Title of my topic was 2-year zoledronic acid treatment in children with osteogenesis imperfecta, a tertiary care center experience. As you know, osteogenesis imperfecta is a heterogeneous group of inheritable conditions characterized mainly by bone fragility, manifesting as recurrent fractures, delayed motor development, pain, and impaired quality of life. Intravenous bisphosphonate pamidronate is already an established treatment of OI. Another intravenous bisphosphonate, zoledronic acid, is now being used for treatment of OI, but the data are not available for most of the centers. Aim of this study was to assess the response to treatment with zoledronic acid in children with Y after a period of 2 years. Coming to materials and methods. In this observational study, patients with Y attending our center were treated with IV zoledronic acid every 6 monthly as part of their clinical care. They were receiving supplementary doses of calcium carbonate and vitamin D, and doses were continuously modified according to the follow-up of lab values. Monitoring of response to treatment was done by clinical assessment, including the number of fractures per year, degree of bone pain, improvement in motor development milestone, and measurement of height and length STS. The study included total 10 patients. They were given zoledronic acid IV at a dose of 0.05 mg per kg every 6 months. And all patients were analyzed at baseline and at the end of 2 years for biochemical parameters and clinical severity score as proposed by Eglan et al. With few modifications. First one is the original table, which included average number of fractures per year, gross motor development, degree of long bone deformity, height SDS, and BMD. To make it more practical for our scenario, we have done few modifications in this severity score. We have added a new clinical parameter, degree of pain. We have modified.
Dr. Angat, your voice is not clear. We are not able to hear you.
Madam, now I am audible, madam. Hello.
Yeah, you're audible.
In modification, we have added degree of pain, gross motor development. We have modified, and BMD was not included in this study because of financial constraint in our setup. Coming to the result, total 10 number of patients were there. In 4 of them, family history was positive. 4 were male and 6 were female. After 2 years of treatment, as we can see from the table, Y patients showed a significant drop in fracture rate, improvement in ambulation, and relief of pain. There was significant improvement in height SDS also. Clinical severity score was significantly reduced after the 2 years of treatment. There was no significant change in biochemical parameters, including serum calcium, phosphorus, and PTH, except significant reduction in alkaline phosphatase. Now concluding this study, zoledronic acid proved to be effective in the treatment of OI. The biannual infusion protocol was convenient to the patient. The use of clinical severity score with few modifications proved to be a valuable tool for the assessment of response to treatment. Thank you. That's also.
Do we know, do we have data as to which type of osteogenesis imperfecta all of these were?
Yes, madam. Actually, these were genetic analysis was not available in all of the cases, madam. But according to silence classification, they were divided into either mild or moderate or severe. Only genetic analysis was available in 2 of the cases. The rest were divided on the clinical and fracture radiological feature basis, madam.
Okay, so if it were a milder variety of OI, were you able to see if the duration of zoledronic acid could have been reduced, could have been prolonged?
Yes, madam. Actually, we are following up the madam because data was only available for at the end of 2 years, and this can be prolonged for more up to the 4 years. Like new guidelines are coming, they are using zoledronic acid for the period of, or even pamidorine for the period of 4 years. And few recommendations are telling that we should continue up to the age of growing of the bone, like till the patient enters into the puberty.
Did you review the literature and see how many studies are there from India with regards to zoledronic acid in OI?
Madam, we have done review of literature, but most of the literature is available from the foreign, madam.
Yeah.
Yes,
so that's great that you thought of doing this study. Interesting, very good.
Okay. One difference was, madam, in their study, the reduction in height SDS was not so much significant, but in our study, there was significant improvement in height SDS, but this could be because of some mild cases in our study group. So you got a very significant improvement in height SDS also. That was not in other studies.
Do you know any novel therapies or any new agents which have been tried for osteogenesis imperfecta?
Sir, even growth hormone treatment is being tried, sir.
Okay. And what about teriparatide?
Sir, denosumab, they are, I think denosumab is being tried, sir.
Okay. Teriparatide?
Not aware of, sir.
Okay. I think this is a very good study. Only thing is, if you can do the genetic testing and classify the types, then it will be a very good study.
Yes, sir. Actually, you tried, sir, but because of financial constraints, sir. Also, we are not able to get BMD of each and every patient, sir. Only 3 or 4 were having BMD, so we couldn't include in our criteria.
I agree with Ashish. It's a very good and useful study for most of us. So I think you should apply for some grants and complete your study.
Okay, madam. I will try, definitely.
Okay, ma'am, we have done with the posters for today.
Thank you.
Thank you, ma'am.
Sumaya, I can see some bone quality characterization.
Ma'am, actually, yeah, there are 2 people who have not turned up, ma'am, actually. One is the bone quality characterization through time-dependent mechanical test. So that person is absent. And again, primary hyperparathyroidism presenting as resistant hypertension. That person has also not come, actually. So we need to just mark them as absent only.
Okay, so do we mail you this Google Sheet? Or?
Yes. We will just we have messaged it to your numbers, ma'am. Please mail the completed sheets to that email ID.
Okay, your email ID, right?
Yes.
Okay.
Thank you so much, Ashish sir and Sridevi ma'am, for sharing the session. Thank you so much for your time. And I think we'll conclude the session. Thank you.
Yeah, thank you.
Thank you, Ashish. Thank you, participants.
Yeah, thank you, ma'am.